Good morning. Good morning, everyone. Is it on? Thank you. Good morning, everyone. Welcome. This is the House Study Committee on Evaluating Funding for our Public Health System. And before we get started, I'm going to ask Representative Sharper if he will open us with a word of prayer.
Yes, ma'am. Thank you. Let us pray. Dear Heavenly Father, we just thank you, God, for allowing us to be here today, God. We thank you for the safe travels. God, we ask you just continue to bless us as we do the business of the people, God. Continue to give us the wisdom, knowledge, and understanding we need to make this state and this world a better place. Amen.
Thank you very much. As we get started, I would like to thank everyone for being here this morning and those of you that have followed us through this committee's meetings. This is our third meeting. We look to be wrapping it up. We've had some wonderful information, and we are looking forward to, again, gathering more information today. I'm going to ask each of our members, we'll start, if we could, with Representative Sharper, if you would introduce yourself and let the group know where you're from.
Okay, thank you. I'm Representative Dexter Sharper, District 177 in Valdosta. I've been serving in the House for 13 years. Previously, 25 years ago, I was City Councilman and Mayor Pro Tem in Valdosta. By trade as well, I've been a paramedic for over 35 years, and I've just enjoyed doing what I'm doing here with my colleagues. Thank you.
My name is Lee Hawkins. I'm a retired dentist here in Gainesville. Was born and raised here. I represent the 27th District, which is North Hall and part of East Hall. In fact, you're in my district right now. I presently chair the Health Committee on insurance rules and regulated industries, banking, and some others. But I focus most of my time on health since that's my background, so I'm very happy to be here and learn from the people that are presenting today. Thank you.
Good morning, I'm Angie Osteen. I feel like we're all traveling together, so I might not even need to introduce myself, but I'm from District 169, that is Coffee, Irwin, Turner, and Tift. I became a registered nurse almost 30 years ago and married a farm guy, so we farm too, and I serve on the Ag Committee, Public Health, and Rural Development, and then I was fortunate enough to be put on these committees, a couple of study committees for rural health care and medicine, so looking forward to hearing it today.
Good morning, I'm Butch Parrish. I represent District 158. I live in Emmanuel County. I also represent Candler, Troutland, and a portion of Bullock County. I chair the Special Committee on Health Care and the Rules Committee, and glad to be here working with these folks on public health. Thank you.
And I'm Darlene Taylor, and I represent District 173, which is Thomas and Grady County. I live in Thomasville, and I feel blessed to be here and working with everyone. Lucky for y'all that we're facing you and we don't get to face the lake because we would all have wanderlust. It's beautiful out there today. So we're ready to get started, and if we could, our first presenter will be Jessica Schwindel. If you would introduce yourself. Thank you.
Hi everyone, thank you so much for allowing me to be here today. I really appreciate this opportunity. My name is Jessica Schwind. I am the Institute Director at the Institute for Health Logistics and Analytics at Georgia Southern University. I was specifically asked to talk about return on investment for public health for this committee meeting, and I'm thankful to be here. So just to briefly tell you a little bit about my background and the Institute. The Institute was started in 2022 in response to the pandemic at Georgia Southern University. We really saw where there was a need for service projects in order to help community health, in order to booster population health, and we are super happy to be fulfilling our mission there to transform the health and well-being of communities through evidence-based practices and technology integration. We're really focused on serving the underserved, in particular in rural areas, but we are so lucky to have the opportunity to have served at least 137 counties out of the 159 in the less than 4 years that we've been operating, so really excited about that. That's all because of federal, state, local, and nonprofit partners who have provided us resources in order to do this work. We have done key projects such as COVID-19 mitigation in K through 12 schools, as well as Georgia confinement facilities. We've also done workforce development. We've focused on zoonotic disease and infectious disease prevention in high-risk groups, and we're currently working with DBHCD through the State Abatement Trust for opioid harm reduction. So really proud of the Institute and the whole team that works there. Just to tell you a little bit about myself, I think it helps inform kind of my worldview. I was raised on a farm in Wheeler County, which is the south central area of Georgia. My father is a farmer and my mother is a nurse, and so a lot of the viewpoints that I have are really shaped by my childhood on the farm. I'll tell you, I went to Georgia Tech as an undergrad, New York Medical College, and University of California, Davis as a doctoral student. And because I believe that it takes a village to raise a child, I'm back on the farm in Wheeler County now. I've been with Georgia Southern since 2017, and really thankful to be working in infectious disease epidemiology there with an amazing team, some of the finest folks, present company excluded, in Georgia on this team, so thankful for that. So just to talk a little bit about the things I'll be talking about in the presentation, just a quick overview. I do want to talk a little bit about return on investments and how it's used in public health, because it's slightly different when you apply it in this setting. I do want to talk about findings from the literature. I'm going to quote some research studies. This is not my particular area of research. I'm traditionally in pandemic preparedness and response. I'm not a health economist, but an epidemiologist, but I feel like I can paint a pretty good picture about the return on investments for public health. I will extrapolate some of those findings to Georgia in particular, looking at a particular case example, and there are a couple of additional considerations that I would like to talk about that I think is important as we continue to have these discussions. So I have a lot to cover, so I might be looking at the watch to make sure I stay on time. So the basic idea behind the return of investments is program costs versus economic benefits. When we talk about public health, you know, it's sometimes hard to put a dollar amount on certain outcomes. So for public health, of course, we can look at things like healthcare savings. We can look at much larger things like productivity gains when you're looking at the workforce and their health. We can also look at values of life saved. Additionally, we can look at decrease of disability life years or an increase in the quality of life, because we know all of those measures have ties to the economy. Now, along with the return on investment research, there's also other approaches that are taken, such as cost-benefit analysis, cost-effective analysis, and cost-impact analysis, and all those are about measuring how, you know, the program lines up with benefits, however it may be defined. Again, it could be payer benefits where you're looking at, you know, this is what my hospital bill was, or it could go all the way up to morbidity, mortality costs associated with the population. So there are particular areas where return on investments work. Specific interventions are the best ones that you can look at because you're really able to kind of put bounds on it. So if you have a particular program and it has specific outcomes or specific measurements, that's where the ROI, research in public health, is best utilized. And that could be vaccinations, that could be smoking cessation programs that have, specificity due to this disease. Or, prevent this person from smoking, or lung cancer prevention. It usually works in short to medium time frames. We know health is a long-term game, but when we can really narrow down the time frame that we're looking at, that's helpful. And this is probably the biggest point, we really have to understand what the comparison group is. Sometimes when you go and look at ROI research, the comparison group may be status quo, the way that it's in operation right now, or it could be the absence of any intervention. So that has to be outlined. Additionally, with the literature, researchers, scientists definitely use theoretical constructs in order to simplify reality. That's just so that we can do the analysis, right? So you probably have heard garbage in, garbage out, right? Like your model is only as good as the data that feeds it, and only as good as the variables that make up the model. So very, very important to consider that when you're looking at research. Attribution is also difficult. In epidemiology, we have something called the counterfactual, which is, because we typically use data that's observational in nature and not experimental in nature, ultimately we can't say, well, what would have happened had this one variable changed? So that makes my next point, which is benefits are very hard to say. Yes, it was because of this program that this benefit happened, because there are so many different influences that's happening. Like, health is a really complex topic, and so many different factors go into determining whether an individual is healthy or whether a community is healthy. And it's really important too that we don't try to have ROIs be comparable to one another. So I know sometimes there's a tendency that says, okay, well, if we have a 10-to-1 ratio, or for every $1 we spend, we get $10 back, and then maybe over here in this program, for every $1 we spend, we get $5 back. We automatically gravitate towards the one with the higher return, but that's an oversimplification, because there's so many different outcomes that could come if that program is pulled. So I just wanted to really kind of briefly talk about that before I launch into the literature. So as I said, when you can really define the topic areas, that's where you'll see a lot of ROI research. There is a ton of research on ROI for immunization programs, maternal and child health, lead abatement, tobacco control, many others. And so I'm going to kind of quickly go through some of the research that's out there. Now, I will say it would be fantastic if I had Georgia-specific numbers, but I do not have that data, and so I will be presenting mostly national numbers. I tried to find some recent numbers, but some are, sometimes a little bit outdated depending on what's in the literature. But here you can see every $1 invested in childhood immunization generates anywhere from $3 to $11 in savings, and that's only from the payer perspective. Again, we're talking about healthcare costs. Then you have about another $10 to $11 from a societal perspective. So when we're talking about societal perspective, we're talking about those benefits that are really hard to monetize, such as a loss of productivity on the general level, loss of quality of life, increased disability life years. But we know that vaccinations have a huge disease prevention impact, including vaccine-preventable diseases, diphtheria, measles, polio, rubella. In one study, 322 million illnesses were prevented among children born in between 1994 and 2013, and over 24 million cases averted in the 2019 U.S. population. You can see that there's also cost savings associated with immunization. That's direct healthcare costs, as well as societal benefits again. And of course, as the years go on, when you're looking at 30-year time periods, those numbers just grow astronomically. So immunization programs not only impact the health outcomes, which is what they're tailored to do, but they also have economic returns in terms of workforce and productivity costs and overall cost effectiveness. When you think about pandemics hitting populations, you really think about, okay, well, the middle age, the 18 to 64-year-olds, the people who are contributing to our economy. When a new novel pathogen hits the population, that is the age group that is affected for sure. So vaccination represents one of the most effective cost public health interventions, and I will leave you with the last bullet point, which is the pandemic demonstrated how vaccine infrastructure here in the United States and manufacturing capacity also represents critical national assets as well, because ultimately health security is national security. Now, maternal and child health, looking at ROIs there, family planning, $7 return for every public dollar spent. That's resulting in net government savings of $13 billion. This is in 2010. So early childhood programs, ROIs looking at $1.80 to $17 for each dollar spent, with preschool education showing returns as high as 14% per year. Then also I know in a previous meeting, Dr. Toomey talked about the wonderful home visiting program. Here in national data, anywhere from $1.80 to $5.70 return for every dollar spent for home visiting, and $3.38 saved for every dollar spent on prenatal care, especially when you're looking at low birth weight infants and reducing those numbers. From a maternal health crisis and potential savings, we know that a lot of maternal deaths are preventable, and so when you look at these numbers, they certainly add up as well. Looking at lead abatement, overall, each dollar invested in lead paint hazard controls results in a return of 17, all the way up to $221 with a huge savings. And you know, public health lead abatement programs are so important, and Georgia Department of Public Health has one. Cost versus benefits, looking at cost of lead hazard control ranging from 1.2 to 11 billion. That's also looking at benefits including medical treatment, lost earnings, tax revenue, special education, ADHD costs, and criminal activity. There is a huge amount of research that links lead, environmental lead to things like IQ, crime prevention, and ultimately lead abatement has very high numbers in terms of ROI, similar to vaccines that we just talked about. Also with tobacco control programs also represent exceptional public health investments with returns ranging from $2 to $112 per dollar invested, depending on whether you're looking at the healthcare savings or the broader benefits. Of course, we have state-level tobacco programs, and you can see from Florida to Arizona, there are huge ROIs that are being reported. Chronic disease prevention, which is something that is really on all of our minds these days, especially with the increase of heart disease and stroke and diabetes. We know that the economic burden of chronic diseases is huge, and that it takes up a large amount of our annual healthcare expenditures. There are different programs, in particular looking at diabetes prevention, looking at heart disease and stroke prevention and early recognition, that ultimately ends up costing society a lot of money, whether it is healthcare costs, a loss of productivity, shortened quality of life years, certainly high costs to the United States as a whole. Substance use treatment, typically that is associated with a 7-to-1 ratio of benefits versus costs. When you look at public health and what public health does really well, primary prevention, school-based prevention programs save an estimated of $18 per $1 invested when implemented nationwide. There's also crime and employee benefits. Even when you look at different types of substances and the impact that treatment has on that, you'll see a variety of ROIs that are all positive. Additionally, when you look at treatment, whether it's outpatient treatment, residential treatment, you can see high ROIs there as well. again, looking at prevention, not just treatment, returns high ROIs. With injury prevention, injuries cost the United States $4.2 trillion in 2019. That includes $300 billion in medical care, $69 billion work loss, $3.8 trillion in statistical life and quality of life losses. And so the majority of this is happening in working age adults, which are the backbone of our economy. And ultimately, this is the area that, like the United States Department of Labor with OSHA and other organizations work on. Now, Georgia Department of Public Health has amazing programs that fall under the injury prevention umbrella. That includes the car seat program. Now, nationwide, car seats prevent a large number of deaths as well as disabilities. So every $46 car seat saves society $1,900, which is a 41-to-1 return, preventing deaths and injuries. And also car seat use programs also focus on making sure that the car seats are being used correctly, which have high returns as well. Then there's fall prevention programs with high ROIs, motor vehicle safety devices, seat belts, we know about the utility of those, and older adult fall cost savings program, which I know is a target area as well. HIV prevention and control, HIV infection, is a huge cost to the individual and to society. Lifetime discounted medical costs for a person with HIV is over $400,000, with 60% attributable to antiretroviral therapy. Ultimately, there is a cost savings from preventing those infections from ever happening. Preventing one infection saves over $200,000 in discounted medical costs, with savings reaching over $300,000 if infected individuals are caught early and they get on the therapy and the drugs early. Now, also other areas under HIV prevention is highly impactful, including pre-exposure prophylaxis for people who are at high risk, as well as testing programs have high ROIs. So understanding your status and getting on the therapy as needed. So Georgia Department of Public Health has many key functions. I know that was discussed in a previous meeting, so I won't go through this here, but just to bring up those key functions, I wanted to focus on one particular area in Georgia that is very important, maternal and child health. You know, it's definitely something where we all recognize that maternal and child health in Georgia is something that is important, something that contributes to community health, to community well-being, and so protecting women and children is something that has a high cost, both you know, at the community level and at the individual level. So maternal mortality rate in Georgia is you know, above average, 32.1 deaths per 100,000 live births, and it's estimated that greater than 80% of the deaths are in fact preventable. And the infant mortality rate in Georgia is 7.1 deaths per 1,000 live births. Now, to illustrate this point, and I think it's really important, and going back to kind of the introduction slides, GDPH operates several evidence-based maternal and child health programs here in Georgia that have demonstrated returns anywhere from like $2 for every $1 to like $44 for every $1 invested. Those programs are the cornerstone of many local communities, and of course, you know, there's 159 health departments in each county, right? And 159 departments that are located in each county. And I think when you sum up like WIC, home visitation programs, the immunization programs, the home screening programs, the developmental screening programs, you can really start to see the true ROI of public health at the local level that ultimately compounds to make Georgia great, right? And so I think one thing that is important to point out is when we are looking specifically at, say, maternal and child health, we do have this kind of compounding effects of all of the ROIs, not just at the individual level, but all the way up to society. So like, for example, at the payer level, you will see reduced NICU expenses. NICU can be very, very expensive. Lower costs due to maternal or child complications at birth. Fewer repeat ER visits. Decreased long-term chronic diseases that are seen, right? So that's at the payer level, but then you start to go to the provider level. You have increase in population health. You have decrease in the high-cost, high-acuity cases where people live with lifelong disabilities. Increase, this is a kicker, increase in the amount of time that people can spend on preventative care, which is ultimately the goal, right? Then you take it up to the societal level and you have an increase in academic achievement, increase in workforce productivity, higher tax revenue generation because you have people working, reduced criminal justice costs, stronger economic development. So you can see, of course we know this in public health, but when you take care of the individual, and that has profound impacts on the community, and then when you take care of communities, then that has profound impacts on the state, and so it just compounds one after the other. So that's kind of a quick rundown of the ROI research, and I hope I did it justice. But I do have a few additional considerations I was told that I could mention. So 3 things: the public health workforce, emergency preparedness and response, and then the value of One Health, which I'm really excited to talk about. So public health workforce, I think when depending on who you talk to, when you talk about public health, a lot of people think about clinical care, especially when you're looking at local health departments, when the only staff at the local health departments are registered nurses. We really need to think beyond clinical care, because where public health shines is when people can start to focus on health education and promotion, when people can start to focus on disease surveillance and intervention, when people can focus on environmental health issues. And so I really want us to kind of broaden our definition of the public health workforce, because when we are able to think about preempting things and not just responding to things, then that's really when communities are going to get healthy. And so this field requires diverse expertise spanning data analysis, policy development, community engagement, right? If you think of that one nurse that's in the local health department, how much time does she have or he have to go out into the community and engage with people to bring them into the health department? Not much, because they're busy treating patients. And so I think it's really important that we think of public health as a team sport, and that there are so many people behind the scenes that are working in making our communities healthy. Now, there are key challenges to the public health workforce that have been well documented. Chronic understaffing. There was, I want to say, something like 40,000 positions lost after 2008, 2009 that were never regained. Chronic shortage of funding. Ultimately, the pandemic hit, and a lot of our lives are like before the pandemic and after the pandemic. But ultimately, lagging salaries, burnout, massive attrition, massive turnovers happening, and then funding restrictions. A lot of the funds that public health get are really earmarked for specific issues, for specific topics, and it doesn't allow the flexibility that's needed when you're looking at the heterogeneity of a population. So the public health workforce, I think, is used to doing more with less, but Where this really hurts is in rural areas, because public health, we're a frugal bunch. And we try to look at the best way to make an impact in the community with, limited resources. That's a general story. But ultimately, when you think about the few people in each county that are working in public health, if they're retiring or they're quitting, there's burnout, then ultimately it's not just them as the individual leaving, it's their connections. And in rural counties, connections, who so that you can pick up the phone and say, hey, could you help this person? Or, oh, hey, could you provide services to this person? That whole network leaves. And so I think it's really important to think about what is it that we can do to help support the workforce so that people are passionate about their jobs, so that people are healthy, because ultimately safe and healthy workforce is a productive workforce. The other thing I'd like to talk about is emergency preparedness and response. Wheeler County, where I live, was hit very hard from Hurricane Helene. That came in a variety of different ways. That includes loss of life, as well as loss of livelihood, especially on the farm, destruction of property, and ultimately the cleanup efforts that are still occurring. I don't think a lot of people appreciate what public health does in this area. It's definitely, if public health is a team sport, emergency preparedness and response is an even bigger team. So you have a lot of people from different departments across the state coming together in order to respond to natural disasters. I think really we are going to see more of a requirement on our public health workforce because of increased intensity and frequency of disasters. And I think there are a lot of things that we can do today to really impact the future, and that's looking at communication barriers, after action reports, looking at information management needs, especially in rural areas, socioeconomic vulnerabilities, and also infrastructure vulnerabilities. So for example, in my small county, we may have enough of a workforce to run one truck, paramedic truck, and that we have also a very large prison in our area. And so if that prison has needs, then the county is left vulnerable. And so I think there are a lot of opportunities to work with first responders, with law enforcement, alongside public health, because ultimately, if there's one thing that we learned in the pandemic, it's that health spans all sectors. And so that brings me to my last point, which is due to increasing complexities, cross-sector collaboration is essential. We see that with shared disease threats, with Georgia being a leading state for agriculture. We know the importance of food safety and security, not just for our food supply, but also for many people's livelihoods. That will impact them. We understand the importance of antimicrobial resistance and environmental health concerns. And so this idea of One Health is recognizing the linkages between human, animal, plant, and environmental health, recognizing that they're fundamentally interconnected, and that we can't have, say, a healthy human sector if our animals are unhealthy, as an example. And so this is really, when you want to talk about ROI, this is really a huge value proposition, because when you can leverage diverse expertise in animal health, in plant health, and ecosystem health, then ultimately your ability to detect and respond to emerging health threats is increased, and it builds resilience in the systems, right? So if we know that approximately 2/3 of emerging infectious diseases come from animal sources, and then ultimately a large majority of those come from wildlife populations, then we want to work with our veterinarians. We want to work with our ecologists in order to better understand the movement of disease, as an example. So I'm really super excited to tell you about a new Georgia initiative called the Georgia One Health Consortium. This is a group that spans federal, state, local, governmental, non-governmental organizations, including academic institutions and nonprofits. Currently, we have 119 members representing 35 different organizations, and I am just so proud to say that includes the Georgia Department of Public Health, that includes the Georgia Department of Agriculture, that includes many of the larger universities here in Georgia. And our key objectives with this group is to really increase awareness of One Health initiatives across Georgia, build collaborative projects, and then encourage more coordination across professionals. And you could see that in the example of the H5 response that was occurring recently. So just some final thoughts. Thank you for sticking with me this far. So we really, in public health, have a need to focus on prevention. Again, that's where public health shines. And so there's this prevention imperative where the more time that you can spend on preventing health outcomes, adverse health outcomes, the better prepared we'll be and the less costly response will be. And so the more time that we can focus on that, the better. Ultimately, we do need some evidence-based ROI research specifically for Georgia. It's something that my team would be thrilled to undertake. But the more that we can understand what are the different aspects of the programs that make them successful, the more we can use our limited resources and target those areas. Ultimately, we know about the cost of inaction. We know about the need for sustainability. There are things that we can control, and there's things that we can't control, such as natural disasters. So it is really important that we use this opportunity to make changes in the system so that we have workforce needs being met, and we have communities becoming healthier because the workforce that supports them is also being supported. I am so thankful to live in Georgia. I came back here, and it's a place that is really near and dear to my heart, and I'm thankful for all of the public health professionals across Georgia and all of the amazing work that they do each day. I'm also thankful for the One Health professionals, the veterinarians, the vet techs, the ecologists, environmental health specialists, who all come together in order to impact the public's health. And I'm just thankful that we have this opportunity to speak on these things today. So thank you again. I'm happy to answer any questions you may have.
Thank you for a very interesting and in-depth report. I really appreciate this information. Are there any questions from the committee? Yes, Representative Sharper.
Thank you so much. As you were talking, and I heard more about the One Health Consortium, and when I look at that, in your group, have you guys really considered or even observed a way that your health departments, you know, the health department itself, and then you have your emergency rooms, and a lot of people that can't have, you know, don't have proper insurance or access to it, you see them more at the emergency rooms in our hospitals. Now, with this SHAP program and other programs at the health department, I think that educational-wise, if the hospital could do more education on their end, even at the community health fairs and things you have health departments out, but then also have the hospital out. And sometimes you have different places, especially where they do some of the health fairs, to educate the people more on programs that are at the health department that can prevent a lot of the ERs from being so packed all the time and long waits. So I just wanted to interject with the One Health to look at some possible solutions to where they can work together, collaborate, because that's a big issue, especially all over Georgia. everywhere you have a hospital, the ERs are packed. But a lot of that preventive side or some of the programs they have at the health department can prevent them from having to go to the emergency room where you really have other emergencies that are true emergencies that are having to wait a little bit longer, or the staff is tied up with other things that maybe they have been to the health department because they don't have a personal physician. So I just want to add that in. That's something that you guys can see if we can, have a conversation on.
Absolutely. Increasing utilization of local health departments, absolutely.
All right.
Are there any other questions? I don't see any. Thank you very much for a very, very informative. We appreciate that. Our next presenter will be Kelly Hughes. Thank you. Thank you. If you will introduce yourself.
Look at all these. Oh, okay, great. Well, good morning, everyone. Hi, thank you again, Chair Taylor. My name's Kelly, and members of the Health Study Committee. My name's Kelly Hughes. I'm an Associate Director in the Health Program at NCSL, which is the National Conference of State Legislatures. I don't want to get in your way here.
No, you're good.
Okay. All right. Thank you so much. Great. So for those who may not be familiar with NCSL, we are the national bipartisan membership organization for all 50 states, DC, and the territories. So we're your member organization, and I really appreciate y'all calling on us. We kind of specialize in that 30,000-foot view of what's happening across the nation and lifting up those examples to help inform strong policy making. But I'm also a former Georgian, so I lived here for many years, about a decade, and I'm a graduate of Emory University. I'm also a public health professional, so before joining NCSL about 6-7 years ago, I was at CDC as a fellow, and then was also at a state health department in Minnesota, and moved around a bunch and worked for a national nonprofit in public health. So public health is definitely my background. And I also got married not too far up the street, up in Helen. So Georgia is very near and dear to my heart as well. So really today I'm going to be talking a little bit about some legislative opportunities for legislatures to consider to sustain and strengthen public health. And so with that, just want to talk a little bit about NCSL, who we are. I mentioned we serve all 50 states, DC, and the territories. Really, when a member is elected to the legislature, they are a member of NCSL, and we are there to serve them in the ways that are listed here, but also others. So a lot of what I do in the health program, I direct our population health work, which includes public health, maternal and child health, and behavioral health. And have an amazing team of colleagues. And then we also have a healthcare team and a Medicaid expert, so really there to answer any policy research questions that members have. All right, so diving right in, I'm gonna put this down. I wanna start by just sharing some context about public health that'll really set the stage for the state examples that I'll be highlighting, and then also the federal funding updates that Morgan had asked me to share. I know some of this may be repeated information, so forgive me. I was not able to join the previous meeting, so I'll try to keep the background context short. But when we talk about public health, we're talking about not just the science, but also the practice of improving health of populations, and not just focused on individuals. And this really requires a lot of coordination across local, state, and federal levels, and also really clear ways to measure the impact and the effectiveness of the services that are delivered. So when we think about the roles, we have the federal agencies, really largely CDC is the federal agency responsible for public health. They're really setting that national guidance. They're allocating resources to state and local health departments. They're maintaining laboratory capacity, and really providing technical expertise to state and localities. And then we've got the state health agencies. I kind of think of them as like the mid-level managers, not to sell them short by any means. They're really overseeing those statewide public health programs, coordinating across counties, and then translating those national priorities for the local context within their state borders. And then the local health agencies are really those frontline responders. They're delivering the services. They're really responding to outbreaks. They're on the boots on the ground, public health professionals in the communities. And then in terms of services, This is really, what health departments are charged with delivering. There's a couple of different frameworks, but one that we're seeing come up in legislation more often than others is the Foundational Public Health Services, which I'll call FPHS for short. So this is a framework that is designed and intended for governmental public health. And it really defines the minimum services and capabilities that that governmental public health should deliver and that everyone in the community should have access to, whether you live in a big city or a rural community. And I'll share a little bit more about this framework in a minute, but I just wanted to close also with performance. And so that's really important. How do we measure the effectiveness of the work that public health is doing? And there's ways to do that with a self-assessment. And then there are processes like accreditation, where it's a voluntary but evidence-based, sort of process that use evidence-based recommendations to kind of signal quality and continuous improvement. And I think you might have someone from the Public Health Accreditation Board. Great, so I won't go into that too much. They're the experts. But I do want to just mention, so just to kind of tie that up, so FPHS is kind of what the services, tells us what services people should get. NPHPS, which is the National Public Health Performance Standards, they show us how to improve. And then accreditation is really what's demonstrating the quality. So I wanted to just take a moment to talk about FPHS because this is the framework that a lot of states are using in legislation to set minimum standards. And so it's basically setting the floor, so the bare minimum of what a governmental public health, both local and state, should deliver to communities. There's foundational areas. I know it's probably hard to see this, but the foundational areas I think of as programs. So what are the programs? The communicable disease, the environmental public health, maternal and child health, and then there's foundational capabilities, and that's kind of like the skills of the public health workforce. So community partnership development, policy development and support, accountability and performance management, communications. So that's sort of the framework in which states are. I think what's really neat about this framework is that it can be adapted to the local context and the state context. And so that is what a lot of states are doing, and that's what we'll get into and talk about a little bit today. So in terms of policy options, there are many. This is just a small kind of snippet of policy options and levers that are available to state legislatures to strengthen state and local public health systems. When we think about strengthening public health, you can think of it like building a solid structure, and there are sort of three main pillars. That's standards, resources, and accountability. Standards really ensure that, like I said, everyone in a community has the same baseline protections, and that's through these minimum standards that allow flexibility also at the local level. And as I mentioned, a lot of states are using FPHS as that blueprint. Also, standards really only work if there are resources to implement them. And that means having funding that's steady and predictable so that communities or really health departments aren't really left scrambling when those one-time federal dollars are run out, like we are seeing with the COVID relief dollars. And then the third pillar is accountability. States have adopted key performance indicators or KPIs that are tied directly to FPHS. And some examples would be like immunization rates or outbreak response times. And then, by tracking delivery capacity and outcomes and making sure that data is available publicly through, public dashboards or reports to the legislature that are published online, those are ways that states can really build that transparency and public trust and then evidence for improvement. And then at the bottom, we've got this sort of complementary strategies that, like shared services, workforce development, modernization, accreditation, that can really only strengthen that structure. Okay, so we're going to get into some state experiences, and they are state examples, but I wanted to also, with each state example, really give you a bit of the background, like how did they get to this place where they wanted to pursue legislation to strengthen public health. So the first one is Indiana, and I think of this one as probably the most comprehensive. I'm also coming in as an outsider, and so this is using all publicly available information. But with that said, I think this is one of the most comprehensive examples in terms of evaluation data available too. So just wanted to flag that. So their push to modernization began in 2021 when the governor created this public health commission. The commission's job was to take a hard look at Indiana's public health system and how it was working and recommend ways to strengthen it. So in 2022, the commission released a major report identifying 6 key challenges, and among the top of those key challenges was funding, governance, and workforce. And then the legislature responded in 2023. So on the right hand, you'll see the legislation. So with Senate Enrolled Act 4, and that legislation established core public health services in law, created new local health department funding, set training and qualification standards for health officers, and then added performance reporting as well. And then that same session, the budget bill is House Enrolled Act 1001, and that appropriated $225 million in new biennium public health funding. Before this, counties were receiving $7 million a year from the state, so this represented a 1,500% increase in Indiana's annual public health investment, and that was with no new taxes. I don't know how else they did that, but that's the information I was able to find. Together, these actions really laid the foundation for Health First Indiana, and that's really this new initiative that's reshaping how the public health system is functioning in Indiana. So really, like, what is Health First Indiana? It's a state and local partnership. Participation's voluntary, so counties can opt in, and then they retain full authority and local control. The state provides 80% of the funding, and the counties match with 20%. Each participating county gets a minimum of $350,000 annually, and then more based on population and vulnerability measures. And then in exchange, when counties opt in, they are agreeing to deliver a defined package of 14 core public health services. And those are pictured on the right, also probably small to see, but just had those are there for reference. I also included some key resources so you could dive into some of these a little bit deeper. But they have the ability to adapt how they deliver these services. The legislation also builds in accountability, and so the state sets statewide and county level metrics. They also publish annual reports online and then provide reports to the budget committee. And local health departments have to report on outcomes twice a year, and those reports are also posted publicly on the Your Community Info link in the upper right-hand corner. So there's a lot of evaluation going on right now. There's a preliminary evaluation report that was published in December 2024, and that captured performance from January to August of 2024. All 92 counties have participated voluntarily in the program, so they have a 100% participation rate. And then in terms of services delivered, 89 local health departments delivered over 581,000 individual services across all these core public health service areas. Another source reported that there was over 1.4 million services delivered in year 1 alone. And researchers, in terms of ROI and what Jessica was presenting earlier, researchers estimated $95 million in cost savings from the initial investments for just 3 of these 14 service areas. Those were prenatal care, blood pressure screening, and fall prevention. A full evaluation report's expected in early 2026, so I think that will give a more complete picture of the estimated cost savings and the services delivered. So that is Health First Indiana. Now we're going to pivot to Massachusetts. So what's unique about Massachusetts is that they have 351 local boards of health in their state, which is the most of any other state. And that means that services can sometimes feel fragmented and that they really vary from one community to another. So in 2016, the legislature created the Special Commission on Local and Regional Public Health, and they were really assessing how well municipal and regional public health systems were working and then recommend ways to strengthen the delivery. That led to 2019, the commission released the Blueprint for Public Health Excellence, and that identified recommendations in 6 key areas, one of which was public health standards. So building on all of these findings, the legislature passed the State Action for Public Health Excellence, or SAFE Act, and that was signed into law in April of 2020. And that act required the development of minimum standards and also established a grant program. By 2023, SAFE grants were supporting 91% of municipalities and they had invested over $50 million to kind of help towns share staff and modernize data and strengthen basic services. So then the latest iteration is SAFE 2.0. That was signed into law in November 2024. And how that differs is that it's really just SAFE 2.0 took what worked in SAFE 1.0 and made it all mandatory, consistent, and sustainable across the state. So it made the foundational standards mandatory so that everyone had access to the same baseline protections. It codified workforce training and performance standards so that all of the local health departments are held to the same expectations. And then kind of what's unique about Massachusetts in this example is that it supported shared collaboratives, so that, for some of those smaller health departments, they could rely on other, leveraging services from another health department without having to increase their own internal capacity. So really kind of that shared service model, and also built in some uniform credentialing and data systems. Accountability is central to SAFE 2.0. DPH, the Department of Public Health, must estimate funding needs annually and report to the legislature. Public hearings and legislative reports are providing transparency, and local boards are reporting on metrics, which are then aggregated and published by the state. And so that really allows policymakers and residents to track the progress. So far, progress to date, nearly every city and town is engaged in SAFE-funded work, and many are participating in the regional collaboratives that are really helping to fill staffing gaps and also improve efficiency. And workforce credentialing and data modernization are underway, and those are some of the big systems changes that will create consistency and allow the state to measure performance over time. And I included the performance standards link so you could dive into that, and also the SAFE 2.0 guidance document. Excuse me. So next, Missouri. We have 3 more state examples, and then we'll get into some federal funding updates. So Missouri is a little bit different. There is no legislation attached to this example. It's voluntary. It's a grassroots-driven initiative that, similar to Massachusetts, they have a really complex and fragmented public health system. So they have a state health department and then 115 autonomous local public health agencies with different structures and programs and funding. And so in 2017, the Healthier Missouri, I'll call it Healthier MO initiative, was launched in partnership with the Missouri Public Health Association and the Missouri Department of Health and Senior Services. By 2018, 2019, stakeholders came together to adapt the national FPHS framework for Missouri, and the result is the image on the right. And then in 2020, Missouri conducted its first statewide capacity assessment of local public health agencies to really assess, can they deliver these services? What are the gaps? Building on that assessment, a report was released in 2021 detailing the capacity to implement the model. And from 2023 to 2024, the Missouri Department of Health and Senior Services and the University of Missouri really launched the FPHS gap analysis project, and they're quantifying the capacity gaps and workforce needs and resources. So they're really trying to calculate the true cost of statewide FPHS delivery. So there's no legislation here yet. I think we'll be watching to see if that does evolve in the future. But really, this is kind of more focused on process and understanding the issue and resources that are needed to set the stage for potential policy decisions. So a couple of other state examples, that I wanted to briefly mention. Oregon has really led the charge with their public health modernization through legislation. They created a task force to study the state's public health system and recommended improvements. And this legislation called for foundational public health capabilities and programs statewide and ensured sustained state funding. So that was HB 2348 in 2013. Then in 2015, they implemented these recommendations through legislation and required a modernization framework and performance-based funding for local public health authorities. And then building on that, in 2017, they empowered the Public Health Advisory Board in Oregon to establish accountability metrics. So it's sort of been like a step-by-step process every 2 years. And since then, the legislature has provided over $60 million in general funds to support these modernization efforts, to build regional public health models, to establish minimum service standards, to expand workforce training, and to ensure regular legislative reporting. And then with Washington, they have also advanced their public health modernization through FPHS framework. It started with a baseline report in 2018 that identified a $225 million annual funding gap needed to fully implement FPHS statewide. Second substitute, House Bill 1497 in 2019 codified FPHS and defined the governmental public health system and established ongoing funding to address the gaps. Since that biennium, the legislature has increased investments, reaching $162 million by FY24, and that addresses 72% of that funding gap to ensure access to FPHS in every part of the state. And so over those 6 years, this sort of phased approach has expanded FPHS availability and strengthened system capacity through the core standards, annual reporting, and funding. So you'll kind of see a pattern there. And I included some key resources for both of those state examples at the bottom. But lastly, the examples that I've discussed are not exhaustive. There are a couple of other examples that I was able to find. Colorado passed the Public Health Act of 2008. It's SB 08-194, and that called for major reforms to the state's governmental public health system. And then North Carolina has statutory language also that explicitly mandates essential public health services at the local level. But I wasn't able to find legislation that they've codified the structured funding and the foundational capabilities and accountability with measurable outcomes. Okay, so those are the state examples. Morgan had asked me to touch on the federal funding landscape and key public health proposals. And as you all know, this is very much an evolving landscape with budget discussions happening in very real time. So I'm gonna present what we know at this point and then hope it's helpful to inform your next steps. Okay, so I thought it might just be helpful to, and I know you all know this, but just to step back and kind of understand how federal funding flows to state and local health departments. You know, federally, CDC is the largest contributor of public health funding. Well, federal funding in general is the primary source of support for public health, and CDC is the largest contributor. I think one thing folks may not know is that 80% of CDC's domestic budget goes out the door to state health departments, local health departments, tribes, territories, and community partners. For state health departments, about 50% of their funding on average comes from federal sources. And that's true also for local health departments. In fact, a little bit more than 50% comes from federal sources. And that's either directly routed, that's actually either received directly from the federal agency or routed through the states. And so what this looks like for Georgia, I know these charts at the bottom are pretty small. But there was a KFF analysis from April of this year that examined CDC FY23 funding obligations to state and local jurisdictions. And there were many findings, but one of the findings revealed that funding levels varied widely across states, ranging from $46 million to $1.4 billion. Also, funding was concentrated among a smaller group of states, with the top 10 recipients accounting for half of the funding that went out the door. And the top 5 states accounted for a third, and Georgia is one of the top 5 states in terms of receiving funding from CDC, per the chart to the left. And then when you standardize by population, CDC funding ranged from $35 to $314 per capita, and Georgia's right around that $40 per capita level. Okay. So if we take a closer look at Georgia, the public health funding structure reflects a lot of those national trends that I just highlighted. We know, according to the Georgia Health Primer for state fiscal year 2026, the state's $67.2 billion budget really draws from a range of, or a mix of state, federal, and agency-generated funds. Roughly 1/3 comes from federal. And so for the Department of Public Health budget for FY26, totals $435 million, and that represents about 6% of state health spending. Approximately half of DPH's state funding is distributed to county health departments. And I know we have DPH in the room too, so they can probably speak to this better than I can. So that's just I just wanted to give you a picture of how funding flows from CDC to state and local health departments and what that might look like in Georgia. So if we look at federal budget proposals, so we'll start with the president's FY26 budget request. That was released in May, sent to Congress. As with any presidential budget, this is a proposal. Congress has the authority to adopt, reject, or amend. For public health, the proposal signals major funding reductions and structural changes. HHS would see about a 22% cut, about $33 billion less than FY25. And then CDC would be particularly impacted with about a 37% reduction. So that's about $3.6 billion less, and also the elimination of numerous public health programs, which will directly reduce direct federal support for state and local public health work. The proposal would also create a new administration for Healthier America, AHA, and that consolidates parts of HRSA, SAMHSA, CDC, and other agencies with a proposed budget of $20.6 billion. And I included a link for a more detailed breakdown. If it really is in the context of public health, the breakdown that I included there. So pivoting to Congress, we can, both the House and the Senate have released their LHHH, their Labor, Health, and Human Services bills. In the Senate, the FY26 proposal would fund CDC at $9.15 billion, and that's a $50 million decrease from last year, but also modest in comparison to the administration's proposal. The House version of the budget includes a deeper cut to CDC funding, but not quite as steep as what was outlined in the president's budget. And so really the key takeaway here is that Congress and the administration are pretty apart in their visions for, at least the budget for FY 2026. And I think this sets the stage for negotiations as they work towards a final budget agreement. So what does this mean for states? And this is my kind of final wrap-up slide here. On the status of appropriations, because Congress has not enacted an FY26 funding or a continuing resolution, they have not enacted FY26 funding or a continuing resolution. The federal government entered a shutdown, and we are currently in the shutdown right now, as you all know. Also, secondly, COVID supplemental funding is winding down. So these were always temporary, and in some cases, but also in many cases, funding is being rescinded. So the picture has been a little bit complicated by litigation, but according to a KHN analysis from August of this year, it shows that in Georgia in particular, 16 COVID grants were terminated, including $38 million that had gone to the Department of Behavioral Health. And so that's what you're seeing on the map on the right. So I think the big picture and the implications for states is this is just a time of uncertainty and instability. And I think with the shutdown in place and the funding cliffs from expiring COVID dollars, and then the ongoing clawbacks, we're just not really sure what this looks like for public health. And so I think why that feels important or why it matters is that federal dollars account for about half of state health department budgets. And so I think states are going to have to be creative and innovate in how they think about funding public health moving forward. On that note, I think that's all I have for you, but welcome any questions that you may have, and also happy to take any questions back to and respond directly, individually.
Thank you very much. Again, very good information. Does anyone on the committee have a question? Okay, one of my questions that came to me is looking at some of these numbers, and so much of the money is given in grants that are for specific usage, and that can be a handicap in a lot of areas. Do you see any changes? Do you think that there is going to be any looking at a different way, like just by population, or right now it's still in limbo? We don't know what they're going to do.
Thank you so much for your question, Chair Taylor. So is that in reference to the funding that would come from CDC?
Yes.
That's a great question. I would love to connect with colleagues and see if I have if I can provide a helpful answer. My sense is, I think it will depend on what happens with the proposed changes to the agency itself. Right now, I think based on the president's budget and proposal, a number of programs would leave CDC. And so I think it will depend on how AHA, if we move forward with the new agency, how they are granting funding out, which could look more like block grants. And then CDC, I think it will just depend on, they have mandatory programs, they have discretionary programs, and so I think for the mandatory programs, those would probably remain grant through, would be funded through grants, but the discretionary, I think, is up for debate. So I'd love to follow up with you on that with a better answer.
One other question, that has to do with the organizational structure. We have so many counties and a lot of local control. There is not, the buck can be passed anywhere. And that's one of the things, I'm wondering how other states, is there a be-all, does it stop at the state level? Or is it shared authority, I guess, is where I'm going.
Yeah, that's a great question. I'm sure our FAB partners can answer that better, but but there are a couple different models, and I don't know that there is a gold standard or an ideal model. I think there's a centralized system where the state health department is really the authority, and then funnels money to the local health departments. I think there's also decentralized, where the state health department is a key partner, but the funding is really kind of, it's sort of locally driven. And then there's a shared model, which is, I think, what is the model that Georgia has.
It is.
And then there is a mixed model. And I couldn't speak as well to that one, but happy to also follow up with more
Yeah, I would like to
information.
see more of that. Again, we came through the pandemic very well, but it does get very difficult because of the size of some of our counties. And we are so spread out. And I think it's sometimes hard to have, where is the final leadership coming from?
Right, absolutely. Yep, thank you so much for that question.
I think we do have a question. Representative Sharper?
One quick one. When we're talking about the funding, we noticed that in the state of Georgia, there's several counties that have been doing like 40%. If you look at it, someone's giving more percentage in the health department, budgets, things like that. And I'm just thinking that as, you're the organization you're with, that we can get some type of guidance, and also we as legislators, we honestly need to look at that situation of the counties, the portions that they're putting in, and what the state is doing, because the counties are not mandated on a certain percentage right now, a lot of them. It's like they look at their budget and they see what the needs are, and the thing that we're having a lot of federal cuts, it's got to come from somewhere. So what happens when the county say, look, we're doing all we can do now. That's it. We're actually been doing double in some cases of what we, really not required, but we've been doing this so we can take care of the people in our county. So we need to really put something in place. If not, you're going to have basically a local shutdown, the county saying, this is all we're going to do. And the state say, well, we have the funding, but you can't go back year after year, year over year, just saying we're going to do it like we've always done it. Because when the county say, look, we don't have that extra funds to help the health department, and the state say, well, we didn't budget it either, now it's going to fall on somebody. So we need to have somebody that's going to be totally accountable, but I think that's something we really need to look at as soon as possible.
Thank you so much, Representative Sharper. Would it be helpful to share information on like per capita calculations for local health departments? Sort of like what is recommended? I'm not sure exactly what the evidence shows, so I'd have to dig in, but I know that there's been a big focus across states on calculating per capita. So like what do we need at the local level? What is the ideal level of funding per person? Or how do we come to those calculations? Like would that be helpful, or is there?
Yeah, I mean, that would help a lot, because at the same time, you can't always go by population, for one, because there's certain counties where people make more money. It's the cost of living, it's the amount of money they're able to make. So therefore, it's got to be some serious number, some serious formula that we got to have to come up with. Because if you have a poor county and they have a good bit of people, that doesn't necessarily mean that they have that kind of money to be able to take care of, because maybe a more poverty-driven community with more chronic problems, and it's got to really add up a certain way. So that's got to be something we need to really look at to come up with that particular formula that have a lot of different parts to it, that you put those numbers in, plug it in, and say, okay, this is the ideal number for your county based on your county.
And a number of states, thank you for that, a number of states factor in population size and vulnerability measures for that very reason, right? So there's like a baseline, and then they'll look at these additional measures and bump funding, allocate funding accordingly.
All right, thank you.
Yes, thank you.
Thank you very much. This is great information, and we appreciate your coming. Oh, okay,
I
I'm
just
sorry, I
wanted
didn't
to
see.
say quickly, why don't we also ask you for not only per capita spending, but county average income per capita? I think that would help on those numbers.
Yeah, I will look at that. Thank you so much.
Thank you so much. Our next speaker will be Rena with the Public Health Accreditation Board. If you will introduce yourself and share your information. Thank you.
Hi, good morning, everyone. Thanks so much for having me. I'm really excited to be here to represent the Public Health Accreditation Board, or FAB, and share a little bit. I'm going to focus in a little bit on both the accreditation program and this body of work called Systems Modernization, Systems Transformation that Kelly was mentioning as well. A little bit about FAB. We are a nonprofit organization based in Northern Virginia in the DC area, focused on championing performance improvement for health departments.
Can you get a little closer to the
Yep.
mic? Thank you.
Championing performance improvement, strong infrastructure, and innovation for the public health system. We are the only governmental public health accreditation body in this country. And I'll talk more about what that is and what that looks like in just a minute. And then we have, again, this whole body of work that's focused on public health system modernization, public health transformation as well. Just to share a little bit about myself, I'm Rena. Though I live in Washington, D.C. right now, I am a daughter of Georgia, so very excited to be here. I grew up in Augusta and Richmond, Columbia counties, and I went to school. I went to Emory University for both my undergraduate and grad school, worked in Atlanta for a bit before moving to D.C., and my first job was at a public health department. And I also worked at the DeKalb County Health Department for summer surge capacity. So all that to say, my Georgia roots are very near and dear to my heart, and really excited to be here to talk about strengthening Georgia's public health system. So again, I'm going to focus in a little bit on kind of the program of accreditation and what that entails, and then again, these approaches towards transformation, and some tools and supports that are available to support y'all's efforts here in Georgia. We have this definition of transformation at FAB. I'm not going to read this out, but really it's thinking differently about how the public health system should operate. I think there's an approach to kind of modernization or transformation that's grounded in how do we make these small tweaks and where does that get us? But really kind of this body of work around public health transformation is taking a step back and thinking about what do we want to look like? What do we want to offer as services? How do we want to be structured? And then implementing efforts to get there while also thinking about those incremental improvements. So really kind of that reimagining of the public health system, which y'all are doing here in Georgia, as well as kind of those tweaks to the system that can make things better. We are guided by two public health frameworks. I think these are the core public health frameworks in public health. And I want to name these. I know Kelly mentioned the Foundation of Public Health Services. The 10 essential public health services is really about the responsibility of the entire public health system. So there's the health departments, and then there's every other entity that has a role to play in public health, whether that's healthcare, whether that's police, whether that's fire, whether that's social services. So really, what's the role of public health as you think about kind of the system of entities that are engaged in public health activities? The foundational public health services, as was shared earlier, is really about this framework for what is the responsibility of governmental public health. And so that's kind of the distinction between these two frameworks here that really guide public health departments and public health systems. I won't go into details. Y'all heard kind of the pieces of foundational public health services here, but do want to just highlight that bottom box is really what is being named as public health infrastructure. These are the foundational capabilities or cross-cutting skills and capacities that are needed everywhere for public health to work anywhere, and really kind of public health infrastructure. And then those foundational areas above are essential programs that are needed everywhere. What I will highlight is the question we often get is, what about everything else we do that's equally or more important? And though it's very small on this graphic, the line that says community-specific services across the top, that encompasses everything else that agencies and public health systems do to deliver services and protect communities. But without that core infrastructure, those are not able to be delivered as effectively or efficiently. So it's essential to have that core infrastructure in place. Jumping into the accreditation program, so as I mentioned, FAB is the accrediting body for public health departments across the country. That's state, local, tribal, territorial. We also have VRHS, or Vital Records Health Statistics accreditation, and Army Public Health Installation accreditation as well. The standards and measures are aligned with both of those frameworks that I mentioned, the essential public health services, disappear, and the foundational public health services. So it includes both the responsibilities of governmental public health and assuring the rest of the public health system is doing what it's supposed to do. Accreditation is not about the how, but it really describes the what. So the standards and measures, which are grounded in evidence-based practices, they're developed with the public health field, and they're continually updated. We're actually going through a revision process right now, are, again, grounded in the what that health departments should be doing, but they don't say the how. That's really up to the community context, community-specific decisions. It's a measurement of performance, and it's a recognition of achievement. So it's a 5-year recognition, and then there's reaccreditation. We're actually also going through a process to update our reaccreditation process, so that could look differently in the future to add even more value. The other thing I'll note here is that public health accreditation is not about clinical or individually delivered services. It's really about population-based programs and services. So not those clinical services that health departments may provide as well. Really proud of our 450-ish health departments that are accredited across the country. Here's our map, our current map of those health departments here, and you can see kind of the breakdown in the box. And yeah, just really proud of kind of everyone who's leveraging the program of accreditation to advance their work. And I'll talk a little bit about kind of value and impact that we're seeing in just a moment. I'll also note that we also see many health departments who may not decide today is the right time for them to pursue accreditation, to really use the standards and measures that exist to drive what their health department does. So though they might not go for accreditation, they're still using the framework and the standards to really help them to implement services within their communities. And then I'll just name that we also launched a few years ago a program called Pathways Recognition, and this program is really kind of a step into accreditation. It's for smaller or less resourced health departments that still want to do something but may not be ready to pursue full accreditation. And so it's got a subset of the standards and measures, and we're seeing a lot of energy around coming together as cohorts to go through pathways together in a variety of different states. Celebrating Georgia a little bit. We have 4 accredited health departments, 2 are reaccredited within Georgia, Georgia Department of Health, Cobb and Douglas Public Health, District 4, and Gwinnett, Newton, and Rockdale County Health Department. So really proud of the Georgia activity around accreditation. And I think really some examples are great kind of quality improvement, performance management efforts to really continue to improve the service delivery that these health departments are doing. Great peer leaders. I think we often see these health departments sharing their examples to others across the country. So really wanted to highlight kind of the great work here in Georgia. I won't go into this. I just wanted y'all to have an overview of what the process looks like here, but I will skip this slide. So we have some new benefits impact data out. We don't have all of our impact studies posted yet, but we do have a new value and impact report posted. And in that report, we heard from health departments who responded that they saw 100% kind of quality improvement stimulation within their health departments as a result of accreditation. improved workforce, improved understanding of workforce's strengths, opportunities, improved morale of the workforce as a result of going through accreditation, increased use of evidence-based practices within health departments as a result of going through accreditation, and increased accountability to both internal and external stakeholders, and that includes better partnerships that folks are naming as a result of their accreditation work. And we often like to say, like, accreditation shouldn't be new work that is going on. It might be documented differently, but it's really about the work that's going on, and it's celebrating that great work and then offering ways to continue to improve. I'll just put this here. I won't go through each of these, but really shows health departments' decision-making thoughts around pursuing accreditation and feeling like they made the right choice to apply. And one of the other, this isn't published yet, we're hoping to release some of our newer impacts. But we recently did 3 new impact studies, and one of the data points I wanted to pull out is there was some connection between accredited health departments and feeling better prepared for emergencies and emergency response that was shown as well through those. So I wanted to highlight that. And we're hoping to do even more. I think our accreditation program is still pretty new. I think we accredited the first health department in 2013. And so similar to kind of what was shared in the first presentation, showing that ROI has been a question that we've gotten a lot, and it takes time to show, I think, the health outcomes change. But as we kind of build more health departments in the system, I think can get at some of the other ways to think about how to measure ROI when it comes to public health through the work we're doing around our studies. These are just some of the quotes that folks have left in terms of their thoughts on approaching and implementing accreditation efforts. So I wanted to share a little bit, zooming out into, so that was about the accreditation program itself and accrediting health departments. What we've been doing a lot of thinking around is how do we really support both efficiency and effectiveness across the public health system within a state, so the network of local health departments, if there are district health departments, state health department, and other support organizations. It might be a public health institute, it might be a SACHO, a state association of county and city health officials, it might be an academic institute. And how do we really support thinking about efficiency and effectiveness, leveraging that systems approach, similar to, I think, what y'all are thinking about here in Georgia, from a capacity or technical assistance standpoint, from funding, and from implementation and service delivery across that system. So the who of this is really, again, health departments or other public health support organizations, and the why is opportunities for greater effectiveness, efficiency across the system, and greater learning across the system as well. I'm going to start with, and sorry the slide's a little bit heavy here on the words, but the accreditation-focused state systems approaches. So we're seeing a lot of different models or approaches emerge from different states and how they're taking this systems look to pursuing accreditation and really this kind of QI approach. In Ohio, several years ago, I'm blanking on the year, they actually mandated accreditation for all local health departments, and as a part of that, offer technical assistance and supports from the state to drive local health departments' preparedness and readiness for accreditation and implementation. We do have an impact study coming out on kind of what the impact of that mandate was on Ohio health departments. And there's pending legislation in New York as well for this. There's this kind of statewide support of understanding readiness towards the standards and measures. We call it the readiness assessment. So Missouri is one state that is taking this statewide look. So the state is supporting all the local health departments in taking the readiness assessment, and then each health department will have their results to understand what they can do to continue to advance their efforts, and then the results are rolled up at the state level as well to look across the entire public health system. So that's one approach we're seeing around kind of the statewide assessment. Florida has a unique public health system. They're an integrated public health system, so they had the systems approach to their accreditation work. There are, we considered it a one integrated system accreditation, but all 67 local health departments are accredited under that integrated system. There are other models emerging in Wisconsin. There are state and local reporting requirements. Wisconsin 140 review is what it's called. And so we worked with Wisconsin to think about the incentive where if locals are reporting into the state on certain measures, KPIs, and they're also accredited, how to reduce that burden of having to report twice on those things. So thinking about incentives in that way. Statewide documentation, if a state provides documentation, if a state provides a service on behalf of all local health departments, how might local health departments be able to not have to submit that piece of documentation because the state has submitted on their behalf? In the past, we would have reviewed all 159 pieces of that same documentation. And then learning communities that are emerging across states as well, and then technical assistance and support activities from a systems standpoint. Many states are leveraging their current public health infrastructure grant dollars to really offer that technical assistance and support across an entire state and health department. So that's our accreditation systems work. I'm going to pivot slightly. We consider accreditation kind of a milestone in terms of moving towards public health system transformation. So it's a key part of transformation, and it's a way to demonstrate transformation. I want to zoom out a little bit, and this is kind of building on what Kelly shared in terms of what other states are doing around taking an intentional look at their public health system and thinking about how to modernize. So in working with, and I'll share the states on the next slide, a variety of states over the years, we've, this isn't a perfect graphic yet, where we continually update it as we learn more, but kind of put together this visual of key steps that states are undertaking to really examine their public health system and then modernize it. So that first step is really defining what is the public health system in a state. If it's, you know, the entirety of the local health departments, district health department, state health department, does it include any other entities? Does it include boards of health? So really defining what that looks like and understanding what core services look like in that state. I think many states are using the foundational public health services. They might tweak it a little bit, but really defining that for Georgia or for other states around what does that look like in that state's context. And then really taking these three steps kind of intertwined. First is assessing capacity and costs. What is our current capacity and what are we currently spending related to the foundational public health services? And that's where that kind of per capita number for the foundational public health services is emerging across states. Then there's another part of this is if we were to say we had 100% implementation of the foundational public health services, so it was available everywhere, it was fully funded, what would that look like and what would that cost? So then you can begin to understand what that gap in funding looks like, which is what other states have kind of produced to help them think about, all right, what's our approach to sustainable funding for public health? And then how do we think about how we are structured, how we deliver services, and how we build capacity to implement and build upon the gaps that were identified? And that's where kind of thinking about, all right, what are the state-run services, what are district-run services, what are local-led services, and really defining that to then be able to match funding accordingly and capacity accordingly as well. We stood up a learning community in, I think it was 2017, that started with 3 states, as Ohio, Oregon, and Washington. Then Kansas shortly came on board, and now we have 21 states that are still going strong, really around this idea of public health modernization, public health transformation, doing those kind of key steps in the process, regardless of kind of the impetus. And so I wanted to name these and are happy to chat with y'all about interest in connecting or joining in as well to leverage the learnings from these other states, but really to show, I think every state has their unique circumstances and context, but the what that many states are doing is largely similar. They're doing the assessing and costing, they're thinking about the funding, and they're thinking about how to structure service delivery in different ways to be more efficient and effective. I won't highlight many new examples. I think Kelly did a great job highlighting some of the examples from existing states that are part of our learning community. I'll just name that the impetus, again, might be different for these states. I think in Maryland and Indiana and other places, there's been kind of a commission approach. In other states, it's more of a ground-up approach to then think about what the future policy opportunities there might be, and in other states, it might be in between. I think Montana and Missouri are great examples of that, starting with this ground-up approach to then think about the policy levers down the road. So naming that there's a variety of examples. Kelly did a great job highlighting some of them, and happy to connect with others. And we do have on our website all of the work that these states are doing to leverage to build from in Georgia. I'm going to shift into some of the tools that we have available. These are all available on our website and are built from the learnings we have from the 21st century learning community, from accredited health departments as well, to really support these efforts across the country. I'll dive into each of these in a little bit, but we have a blueprint for transformation, so recently released blueprint that talks about how you can undergo that systematic approach to asking the right questions, thinking about the different components of a system, thinking about governance, service delivery, policy, standards and performance measures, all those pieces, and go through the steps to really assess and then build the future public health system. So we have that available, and it's recently launched, so would love to work with y'all if y'all are interested in thinking about how we can apply it in Georgia's context. We have the FAB capacity and cost assessment. So this is really built from what we've learned from other states' work in this space to do that work of assessment. So what is our current spending and what is our current capacity towards those foundational public health services? And then what would it look like if we were to say we had 100% of those across Georgia, and then being able to name kind of that gap in funding and in capacity to use that information to take next steps with. So we've got a series of support tools and job aids to support use of this, and then also the actual tool itself. And what we usually see in states that are using this tool or doing a similar assessment is doing this across a system. So it's not just about one health department doing it and understanding their information, but then stepping back and thinking about, all right, what does it look like across our system? And then how do we use that information to talk concretely about where are there places where we can evolve service delivery structures and models? Where can we be more efficient and effective, and how do we fund that? The third is the public health workforce calculator. So this is really for health departments that are under 500,000 in population size served, and that's really just because of the data that fuels it. We're hoping to expand this in the future if we have more bigger cities contributing data towards this. But this then allows health departments to take a look at, here's what we have in terms of our current capacity related to foundational capabilities, foundational areas, and then what might it look like if we were to say we had 100%, and it provides kind of an estimated number of workforce needed, with the caveat being it is not a decision tool, it is a planning tool to help inform decisions moving forward. So we like to say that so no one takes it and says, now we need to hire 10 new staff, because that might not be the case. It might be, well, we can think about how we deliver that service differently as well. The FAB readiness assessment I referred to earlier, this is an opportunity for health departments or systems, as Missouri is doing, to look across all of the standards and measures to understand where there are strengths and where there are gaps, to continue to kind of fill those gaps in across the 10 domains and all of the standards and measures that are part of the accreditation process, but really can be used as a guide to kind of self-assess as an organization to continue to build and grow. And then the last piece I'll mention is FAB is home to this body of work called service and resource sharing. It's really about how to better work across boundaries. So that might be within an organization, across teams. That might be across organizations, so health department to health department. It might be at a district level who provides services for multiple health departments, or it might be at another regional level or a state level. To think about how to best do that and how to align service delivery and resources within that cross-boundary structure. Might be across sectors as well. We think about this as kind of the scale from informal, so handshake agreements, to more formal. It might be more formal, meaning MOUs or other kind of agreements in place, or in some places it might be consolidation or regionalization. So really that scale from informal to formal. And it's really an opportunity to think about, again, how services can be delivered differently, more efficiently and effectively across the system. And there's a variety of tools and supports and examples that we have available as y'all are kind of embarking on kind of thinking about the structure within Georgia as well. And these are just some considerations from that modernization state system approach. I think Kelly highlighted many of these in terms of where there are legislative things going on in different states in terms of embedding core services or FPHS within statute. And then there's examples from other states, again, around how assessments are being deployed, and then the work that's being done too. So that's what I have, and yeah, really appreciate the chance to come and dive in. I know this may be a little bit detailed, but dive in a little bit on accreditation transformation. I'm happy to answer any questions.
Thank you. Again, this is great information for us to have. And I don't see any questions. Oh, I'm sorry. Chairman Hatchett.
Thank you, Chair Lady. Rena, you referred to FCs and FAs. What are those?
Yep, my public health jargon's coming in. So the Foundational Public Health Services Framework has 3 different components. It's the foundational capabilities, or the FCs, so that's that public health infrastructure. And then foundational areas are the FAs, which are key programs and services that should be available everywhere. Okay. And then the third piece is the community-specific services that is all the other work that goes on.
I thought it was an actual job or something. So, sorry. You hinted at it and you talked about it a little, but so how long would an accreditation for a specific health department or health take, and what are the costs from y'all? Because I know you don't do it for free.
We don't do it for free. It covers our staff time to support kind of the work that goes through documentation review, and we provide a lot of kind of technical assistance throughout the process. I meant to print my slide on our fees. I can follow up with y'all on what that looks like. It's on our website, but it's pretty nominal.
Ballpark.
Thinking about the work. So it's based on population size served. I think our lowest category is a few thousand. And then for larger health departments, I think it's maybe, please don't quote me on this, but maybe like 30,000 in annual services fees. And that covers the staff time and work. From a timeline standpoint, it really depends on where a health department is entering into the readiness process. If they have a lot of the examples and documentation and work in place already, then it's usually a quicker movement into the process. If they're starting kind of from scratch and thinking about their structured approach and how they're approaching the standards and measures, it usually takes a few years to build up the documentation to then be able to apply. And then once a health department enters, we have a readiness and training phase, which we implemented a few years ago because health departments asked us to have this kind of readiness piece added onto the front. From there through their documentation review and site visit, and then accreditation usually takes about a year and a half if they take kind of that full time in those pieces.
So Chair Lady Taylor, forgive me if I've missed this earlier and it's been discussed earlier, but this is kind of a question for public health, the department. Do we have some sort of, you probably wouldn't call it accrediting for each actual department or county, but I'm sure they have something they have to check boxes for each year to prove that they're doing their job? Is there something out there that exists like that? I think you're with public health, Graham, so.
Yeah, we take a very collaborative approach with our health departments and all the districts. Sorry, gotta get down here. And so there's less of a formal process than maybe the accreditation that she's referring to. We, as a state health department, we are accredited with them, and we do a lot of constant work to make sure that we're documenting all of the work that we do so that we can ensure that we're working with them well.
Yes, ma'am.
So Chairman thank you so much, Chair Lady. Thank you for this presentation. Chairman Hatchett hit on some of those. Don't go too far, because you might be able to answer some of these. So this accreditation, is it similar to Joint Commission for Hospitals? Is that kind of the thought process? This is Joint Commission for Public Health?
Exactly, yeah. So similar to, I think, hospitals, fire, others who have education accrediting programs, this is the equivalent for public health departments.
Okay, so that was what, and Chairman Hatchet asked this, in Georgia, is there there's a standard comprehensive set of standards we're already going by? All of the health departments are going by?
I want to confirm, and I want to get back with you if that's okay with you, ma'am. There's the standard, or the services that we all provide, which we've shared with you guys. But let me confirm and get back if that's okay.
Okay. So then, how is this not duplicating services? That's my question. How is this not duplicating what's already being implemented?
Yeah, I can, and I'll speak from a national view too. I think most states don't have a comprehensive set of standards that are required for public health departments within the state. North Carolina is actually the only state with an accreditation program for their local health departments. Other states have less formal. Michigan has a less formal. Most states don't have this kind of comprehensive grounded in the public health frameworks. There's often reporting requirements when it comes to what's defined maybe in statute for health departments within that state. Oftentimes statutes are very outdated, haven't been updated in many years. And then there might be grant or other kind of topic-specific reporting requirements based on the requirements of that grant. Most states don't actually have kind of this broader kind of look at the entirety of a health department approach and what that standard should look like.
If I can add one thing. We spoke with you all about the master agreement, which is kind of like the agreement that the state health department has with all of our local health departments, which includes those requirements, what services we provide in order for the funding to come down to them from us. It also speaks to the county match as well. So that is probably our closest, the closest example of that type of collaboration.
How often is this looked at? How often is the reporting for county health departments to report to the state? How often do y'all look at that? Is it yearly?
It's maybe not on so much of a fixed schedule, but we do make updates to the master agreement as necessary, as we find new things that we need to add in there.
Okay. How long is the certification? Is it okay if I keep asking, Chair? How long is this certification good for? Once you go through it, like, it's 3 years, 5 years, how long is that certification good for?
Yeah, for initial accreditation, it's 5 years, and then it's every 5 years after that. There's
every 5 years.
Opportunity for reaccreditation.
Is the initial accreditation where the most expense is incurred, or is it, going to go up like everything else does?
Yeah, so there's actually, we do it based off of this annual services fee, so it's split out across the 5 years, so that's how it continues through reaccreditation. And I'll name, we haven't updated our fee structure in over 5 years as well to kind of help the field as well with, we know funding is what it is across the field. And we're also going through a reaccreditation update process. So things might look a little bit differently as we examine kind of what that looks like, and we're working with some health departments to help us inform any changes to the reaccreditation process. So it might be, maybe it lasts longer than 5 years or something like that. We don't have enough right now, but we are thinking about that approach.
My last question. Where did your information come from to come up with this set of comprehensive standards? What did you base that on?
Yeah. So it's based, we pride ourselves in field-driven work, and so it's developed with the public health field. So FAB was actually stood up after all of the several of the national public health organizations came together. So the Membership Association for State Health Departments, ASTO, the Membership Association for Local Health Departments, NACHO, APHA, the American Public Health Association, a couple of other organizations came together many years ago to say, like, we need a accreditation program for health departments. And we need a set of standards across the country that can be applied to every single health department across the country. And so when FAB was stood up, we went through a field-driven process with input from public health departments, public health practitioners, leaders, to create the first set of standards and measures. And then as we update them every few years, we do it through kind of public input processes.
Representative Sharper.
And I would like for you to kind of put this together in your head and see where we are in our state. But we're looking at, the standard operation procedures of what any health department can do, and also the certifications and the license of the people that are actually doing the work at every level of the health department. So I'm thinking here, you have maybe like 18 different districts or so, and then you have a kind of like a director over those. And so I think all those people may get together at some point, meet on things, and I guess Dr. Toomey's office kind of oversee what they're talking about, what they're doing, and saying, okay, these are the things that we're going to do. And we have different health departments have different services. Some of them do because that particular area. So to her point and question of it, so Dr. Toomey's office or some governing board or some authority or some group is taking this data that comes up the pipeline and says, these are the things that we're doing, here's are the standards, this is what it takes for a particular RN or someone to be a fully protocoled nursing, if you will, because you have some that are protocol, some are not. But when we look at the joint commissions and others, they have authorities to say, okay, you're not doing what you need to do, what you're supposed to do, so there are some consequences and repercussions. So I'm wondering if we have something here in Georgia that can do some consequences and repercussions from that level. I think it's more of ongoing versus when organizations come into nursing homes or come into hospitals and say, this is your annual, or we're coming twice a year. But we don't have anything like that in Georgia that we created to go in and say, okay, here's the shake-up, if you will, shake-up time. So I'm just wondering if we're looking, or we have anything like that I don't know about, or just more ongoing things where these directors come up and say, here's some recommendations, this is what's working for us, and they're sharing information and then putting it back out in a good way to improve the quality of care.
Yeah, there's nothing that maybe as formal as what you're referring to, but Dr. Toomey does directly oversee all of our district health directors, all 18 of them, and they meet regularly. We have district health director meetings where we meet fairly regularly to speak with them, to share, what the state is doing and then what the local health departments are doing, so that there can be, knowledge shared between districts, best practices and the like. And then with respect to nurse protocols, the state develops those nurse protocols and then hands them down to be implemented by the districts.
Okay, thank you.
Thank you. I don't see any more questions. This has been great. We appreciate all that you've brought to us today. We are going to take a very quick 5-minute break.
Excited to talk to you guys. My name is Jacob Cooper. I'm Vice President of State Accounts at Bamboo Health. I am not from Georgia, so odd man out. I live in Louisville, Kentucky, but originally I am from a rural community, a tobacco farm in Kentucky that is one of the communities that was especially hard hit by the opioid epidemic. So my passion and my interests lie in working with states and federal governments to figure out how to prevent substance use disorder where you can and get folks into treatment when they need it. So I love the work that I do. My team works with state and federal governments across the country to run prescription monitoring programs, among other things that we do. And that's what I'm here to talk to you about today. Oh goodness, my slide is not formatting correctly here, but I'll just talk you through it. It's okay. No, it's fine. Thank you, though. What you would see on here is an overview of, we're doing a lot of stuff in Georgia at Bamboo Health. In addition to prescription drug monitoring programs, I wasn't going to talk about much of this stuff anyway, but if you have any questions, since it's not on here, it is in the printout, I believe. We are, innovating with the PDMP, with the Department of Public Health. We are doing care navigation. We are connecting hospitals so that they can talk to each other, doing a lot of really cool stuff. For the sake of time today, I'm going to focus just on our prescription drug monitoring program work. At the top, you would see some metrics. They probably wouldn't make any sense to you anyway, so I'll just give you the headline here. Georgia DPH has a really strong prescription drug monitoring program. I want to talk about just a couple of fundamental concepts for PDMPs to ground us in what Georgia has today and where there might be opportunity to expand on that. The prescription monitoring program, for those that are not as intimately familiar with it as I am, and a lot of you are providers, so I imagine that we do have some experience with the Georgia PMP on our committee here. But basically, every state, including Georgia, has a law that mandates that all of the controlled substance prescriptions across the state have to be reported into a centralized database. And that is primarily used by clinicians who are going to log into the system, check the prescription history, and use that information to make informed clinical decisions.
Can you get a little closer to the mic,
Yeah,
please?
sure. Sorry, I can try. Yeah, no worries. Sorry, I think I have the same problem as Graham here. I'm just a little tall for it. Providers are using this every day to log into the system and check on their patient's controlled substance history. Critical information when making a clinical decision. So, like most states, Georgia also has a law that mandates use of this system in certain scenarios, mostly before the decision to prescribe an opioid or other controlled substance. And so the other concept that I want to make sure that we understand is integration of the prescription drug monitoring program. When states pass mandatory use or mandatory query laws, a lot of times what they will do is invest in integrating the PDMP within workflow. So any providers in the room, you know that your day-to-day workflow centers around your electronic health record, your Epic system, your Cerner system. Those are the big ones, but there are hundreds of small and medium-sized vendors that do this as well. Allscripts, Dr. First, MD Scripts, Athena, the list goes on and on. So what states do is they make it easy to access the report. You think about the provider's workflow, they're in front of a patient and they have all of their vitals, their patient record, everything up in their source of truth in that Epic or Cerner system. What integration does is it puts a little button right there on that page that's that one-click access to the patient report. I want to highlight these two concepts because it's kind of fundamentally what the PDMP does and then how we get it into workflow. And I'm happy to report that Georgia is doing a fantastic job on both of those efforts. These are really the table stakes of a PDMP, things that you have to do in order for the system to be effective and to be utilized by providers. A couple of factors as to why Georgia is successful in this area. One, you've got the best-in-class technology supporting it. Bamboo Health, we provide prescription drug monitoring program services to 46 states across the country. So we are the premier vendor in this area, have a great partnership with the Department of Public Health. The other thing that is critical to success here is the team at DPH that is actually running this thing and doing the day-to-day administrative work, getting the word out, doing the epidemiological analysis to figure out, how to use this data to impact public health outcomes. I really can't underscore how strong that team is. We work really closely with them. In fact, I would say if there's anything that you take away from my presentation today, I would very much encourage you to just kind of listen to those folks at DPH. They are the subject matter experts in how a PDMP can be used specifically to improve health outcomes for Georgians and Georgia providers. So that is a really important asset that you guys have. The integration component of this is not easy to do, but we've done it in Georgia. The highways are built, the tunnels into the EHR exist and are delivering prescription history reports today. I want to just underscore that because it's a big, big challenge. There is really no other program that has the footprint that you have, that the state of Georgia has in its prescription drug monitoring program. You are able to deliver statewide, every health system, every pharmacy, the big boxes, Walgreens, Walmart, CVS, Rite Aid, they all use this. The VHA uses this. So this integration is ubiquitous. It is everywhere. And what is currently being delivered today is just a list of controlled substance prescriptions that the patient has been prescribed. And that's great information. But I'm gonna push the envelope here a bit to say that is prime real estate to deliver additional clinical value. You have to, by law, provide the controlled substance history, but what else can a state be doing? And so that's really what I want to talk about today, are some ideas that other states have brought to the table in terms of innovating and maximizing the investment that Georgia has already made in this really robust infrastructure to deliver controlled substance data to providers. PDMPs, many states think of them as a centerpiece of their opioid epidemic abatement strategy. And you don't have to take my word for it. I have a quote up here. This is an opinion piece from an article in The Hill recently. Former HHS secretary and fellow Georgian, Dr. Tom Price, basically is outlining two fundamental things that governments should be investing in order to move the needle on the opioid epidemic. And the two things that he outlines in this piece are, one, distribution of naloxone. I know that's a primary priority for Department of Public Health. The state has made great strides in that. The other thing that he outlines is investment in prescription drug monitoring programs. And so this is the type of program that works well, and when things work well, you may not hear about it often, but it is absolutely a critical tool that I think has more potential with some additional investments. So to talk a little bit about just how other states are thinking about building out this program to add clinical value, to give their providers more insights, I'm going to talk about three ideas that we have partnered with states on in the last year to develop. The first one here, OD Insights, it's basically non-fatal overdose data presented within the PDMP. So a simple concept there. There's some complexity to actually getting it implemented. But what does this mean? This means that when a provider clicks that button and they pull up the prescription history report, alongside it, they're going to see a history of non-fatal overdose events for that patient. This is a game changer in the world of controlled substance monitoring and substance use disorder treatment. I think about when we were first figuring out how to make this work, there was a provider that we talked to from Boston Medical, so world-class health institution, emergency department physician, and he told us a story about a patient that he was treating for a broken bone in the emergency department. He was considering prescribing an opioid for pain. He checked the PDMP, and there was nothing to be concerned about in the PDMP. No history of controlled substance that was alarming. From a purely PMP controlled substance history report standpoint, he might have made the decision to prescribe an opioid. However, he saw on that patient's wrist that there was a hospital bracelet. And then having a conversation with that patient, found out that just 2 days prior in another emergency department, that patient had overdosed, had a non-fatal overdose on heroin. that obviously impacted that provider's decision in terms of what he advised in terms of a treatment plan for that patient. And the, I think, insightful thing here is that data is available. It's out there. It lives within EHR systems today. It's just not in the right place at the right time for providers to act on it. And so that is what we've worked with the state of Ohio, Florida, Alaska has also implemented this. We're working with several other states. I see this as kind of a primary trend in 2026 is states bringing that non-fatal overdose data in there into the PDMP so that you get an idea of what's going on, not only with controlled substance overdoses, but also with the illicits. We can't track those right now, right? They're not being prescribed and dispensed by pharmacies, so we have no way of getting that data. But we can tell when people have had those negative patient outcomes, and we can present that information to providers. So there's one big idea about how to use the infrastructure that already exists at additional value. The next one here, MOUD clarity is what we call it, but this is basically, so MOUD is medication for opioid use disorder treatment. This is buprenorphine, Suboxone, naltrexone. These are the drugs that folks take when they are trying to get on the path to substance use disorder treatment. And so these drugs are really, really important when you talk to treatment providers. And in having conversations with some of our providers that we work with, what we kept hearing is as a treatment provider, we don't know folks stop taking these drugs. We find out days or weeks later when they miss an appointment and they don't show up to get their next prescription for buprenorphine. But the state knows. The state knows when someone has consistently been filling a buprenorphine prescription and then they stop. So why aren't we surfacing that data so that we can act on it, so that we can intervene, so that the doctor or someone in their office can pick up the phone, call that patient, and say, what's going on? How can we help you get into treatment? And so, yeah, that's the big idea. This is essentially a buprenorphine cessation prompt. And we are live in 3 states currently with this, and we are working on an outcome study actually in Massachusetts to show the ROI. I really appreciated Jessica's presentation earlier today. What we're talking about is investment in prevention for substance use disorder. And kind of call back to those slides there talking about how the dollars spent here are result in savings financially for the state, but also I think a lot about the human impact of substance use disorder and the toll that it's taken. Last idea that I'm going to talk to you about today is co-Rx clarity. So this is basically a co-prescription prompt. So the CDC and sometimes state laws advise that naloxone should be co-prescribed in certain scenarios. If the patient is at high risk for substance use disorder, if they have a history of non-fatal overdose, if they're in an opioid treatment plan or program, if they have been prescribed buprenorphine, if they are on high-risk drugs such as fentanyl patches. Those are scenarios in which sending someone home with naloxone can potentially save a life. As I mentioned, it's a big priority for DPH to get naloxone out into communities. This is just another way to remind providers in a system that they are mandated to check before prescribing opioids that it might be a good idea to think about doing this for your patient. So we've got Iowa and Ohio online. All 3 of these are, I think, going to be, we've just implemented these within the past year, so I think that there are going to be a lot of folks going out for these improvements. These are 3 examples. If you want to come and find me after this, I can give you 10 more examples of how states are thinking about innovating these programs to enhance what already exists today. So I want to talk, and I think this piggybacks really well with the other content that we've heard today, about how can you make this happen? Kind of how can we support this? State prescription monitoring programs today are primarily funded through a couple of methods. State level funding, that's going to be legislative appropriations, agency budget. Almost every state has some amount of money that's being allocated to the PDMP. It's invariably not enough to cover everything that the PDMP needs to or wants to do. And so typically that's going to be supplemented with federal grants. Today, the primary funding sources for prescription monitoring programs are going to be federal grants from the CDC and BJA, specifically Overdose to Action, and then there's a Harold Rogers grant that pays for these things. It's not a lot of money that's out there, and as we heard earlier today, that federal grant funding is becoming increasingly volatile. And so I want to highlight for you all a trend that we are seeing in the PDMP industry, which is a shift from those volatile funding sources to new funding sources that are opening up. So opioid settlement dollars. You guys are probably familiar with this. Most states have sued the manufacturers and several other groups involved in dispensation of, overprescribing dispensation of opioids. And so there's a lot of money out there that is very clearly meant to be spent on this type of initiative. In my experience working with the majority of the country on this, states are having a hard time unlocking these funds. There's a lot of red tape and bureaucracy around them. And so far, we've only seen 5 prescription drug monitoring programs that have actually been able to pull down any of these dollars and use it to enhance their program. For the most part, the money's just sitting there because we haven't been able to figure out how to spend it. The other opportunity that I want to highlight is the Rural Health Transformation Fund. Very hot topic right now. We have had multiple states confirm, within their own state landscape that rural health transformation funds are an eligible source of funding for prescription drug monitoring programs. As I mentioned earlier with my background, I believe passionately that substance use disorder prevention is rural health care treatment. And so you can clearly see the connection that can be made there. And the overall, I think, good news here is that these prescription drug monitoring programs have a big impact for not a lot of investment. Looking at just one of these funding sources, rural health transformation, every state is getting a baseline of $100 million from the federal government for 5 years. For less than 1% of that, if it were directed to the PDMP, Georgia could do everything that I mentioned today and have a substantial amount of money left over. So for me, this is a common sense investment that will result in better patient outcomes for Georgians. And we're to go. Again, here are some of the states that have been able to utilize this funds. I won't read it to you. You can check it out. Encourage any of you to talk about it. We actually have a webinar tomorrow on opioid settlement funds where we will have states and sort of federal experts speaking about how to maximize and leverage these funds for individual states. So I wanted to keep it brief today. I'm more than happy to have a follow-up conversation with any of you guys. If I could leave you with just a couple of asks here, it would be, one, think about the PDMP as a centerpiece of Georgia's public health strategy. States that do think of it that way have done some pretty incredible things. And Georgia's program, although at its core it's very strong, there is definitely opportunity to innovate. Number 2 would be, talk to DPH. You don't have to take my word for it as a vendor up here. And maybe these ideas that I've presented are not the best ideas for Georgians. DPH will be able to communicate what their priorities are most effectively. And then the last thing that I would say is help to unlock these funds. This is a lot of money that's just sitting around, and it could be serving the public interest of Georgians. I am happy to talk about kind of the specifics of how these funds are being handled in Georgia. It's different from state to state, but I think that is an opportunity for you guys as policymakers to engage and help move the needle. So.
Thank you very much for identifying possible sources of revenue and income for our public health. I appreciate that. Are there any questions?
When you say you're from up north, are you saying naloxone? Is that the same thing as Narcan?
The same thing as Narcan.
All right, everybody, y'all got that? If you didn't know, that's Narcan down here in the South. No, I mean, it's the same thing, but.
Sorry, I get a little clinical, but I'm just a little referring to Louisville as up north, so that's not how we think about it.
Right, but good presentation. Thank you so much.
Thank you. I don't see any other questions. Thank you very much. Our next presenter will be Kaylin Wells.
You're gonna have to bring that one down. Good, I guess it's still morning. Good morning, everyone. My name's Callan Wells. I'm with GEARS, the Georgia Early Education Alliance for Ready Students. We are a statewide research and policy organization that advocates on behalf of young children, their families, and those who care for them. I guess we're all kind of giving our Georgia chops today. I am a Georgia native. My family spans from Gilmer County to Glenn County. I have never lived outside of Georgia, and I'm very dedicated to our state. So I want to thank all of you for giving us the opportunity to talk to you today about public health funding, which is an incredibly important topic. Last time we met, I was able to introduce Ansley Hill, who is a mother whose child received Babies Can't Wait services. And so I hope that her story will sit with you as I go through this presentation and talk about potential funding mechanisms that we might better leverage to kind of shore up these programs. So, as you've heard many times, the Department of Public Health has a variety of maternal and child health programs. I should add that in addition to being a Georgia native, I'm also the mother of an 18-month-old. So the maternal child health programs are not only professionally important to me, but also now personally important to me as a mother of a young child. So today I'm going to really focus on home visiting and our Babies Can't Wait program, and really thinking about the ways that we could better leverage Medicaid to support these programs. So Medicaid really is the cornerstone of our health system for children. 46% of births in Georgia are covered by Medicaid, and 42% of children with disabilities are covered by Medicaid. So when we can affect Medicaid policy, we're able to really reach a large portion of our state's children. Medicaid offers a more flexible and sustainable funding source than some of the block grants that we receive to support these programs, which don't have that kind of federal match that we can bring down continuously. And what we know is that many of these maternal child health programs are already have elements that are reimbursable by Medicaid. And with a few tweaks to our Medicaid policy, we could even further leverage Medicaid to support these programs. So just as a reminder, Babies Can't Wait is our early intervention program. We screen and then provide services. We, the Department of Public Health, Babies Can't Wait programs, screen and provide services to children with developmental delays and chronic health conditions. The goals are up here, but really this program serves infants and toddlers. And what we know is that with early intervention, we can ameliorate the need for more intensive healthcare services and special education services later in life. Another element of Babies Can't Wait that I really want to acknowledge is their support for family members. So as you heard from Ansley, many parents who give birth to a child with complex medical needs, they don't know how to navigate these really complex and disparate systems. And Babies Can't Wait really serves to kind of give them a crash course in how to be a parent to a child with a developmental delay or disability, and really serves to provide them that support that they need in those first really critical years of life. So Babies Can't Wait operates in health districts, health departments in every public health district and I needed to note this because I didn't say it last time, in Gwinnett, Rockdale, and Newton counties. Easter Seals of North Georgia administers Babies Can't Wait. So our Babies Can't Wait program contracts with service providers who offer care coordination, speech language, pathology, physical and occupational therapies, autism services, and then that really important support for families not just in how to navigate the systems, but also kind of establishing routines in the home, reinforcing skills that children are learning in therapy. So these, speech, physical, occupational therapy, autism services can bill Medicaid and private insurance, but the special instructors and the service coordinators who are also contracted providers and provide that kind of case management, care coordination, and then those, supports for families in the home, they are mostly reimbursed using block grant funds. Some of these tweaks that might support our Medicaid system, support our public health programs using Medicaid. The kind of way that we developed these recommendations is GEARS did a survey of Babies Can't Wait providers across the state to ask them some of their biggest challenges with billing for Medicaid. Or if they weren't billing for Medicaid, like how they might be supported by billing Medicaid. We also surveyed some of the leaders in the public health districts. And that's how we determined these recommendations. So in your folders, you should have a document that looks like this, which is just a lot of words. But it's our recommendations, and it goes into a lot more detail. And I can also provide these virtually so that you can access what's linked here. But first on the list is really addressing our case management hierarchy within Medicaid. So right now there are case management codes available, but there is a list of provider types who can bill case management, and only one entity can bill per month. And currently, the care management organizations are at the top of that list. So if they are billing for case management, then our Babies Can't Wait providers can't bill for case management. So looking at that list and thinking about how we could reorder the list so that Babies Can't Wait providers are able to bill for case management. And you'll see later, also home visitors would benefit from being able to bill for case management services. Again, case management services really, in the Babies Can't Wait program or in the home visiting program will be more intensive than what a care management organization is providing. Second is really looking at our enrollment and paneling processes within the care management organizations. So I mentioned that our Babies Can't Wait programs contract with these providers. They then have to enroll in the care management organizations. There's a number of recommendations here about how we might look at those options for paneling, doing in-person provider enrollment fairs, looking at providers who are enrolled in 2 CMOs and helping them get enrolled in the 3rd and eventually 4th CMO. The third kind of bucket is around increasing reimbursement and standardizing reimbursement. So thinking about a variety of different options here, increasing rates for those service coordinators and special instructors, which we're really grateful to you all for starting with last year. Thinking about loan forgiveness for Babies Can't Wait contracted providers, which came to the top of our survey as something that would be really helpful. Thinking about rate studies for these contracted providers, similar to what the Department of Behavioral Health and Developmental Disabilities has done for their workforce. Simplifying the prior authorization procedures, et cetera. And then the last is really around improving cross-agency data sharing and coordination. So having the care management organizations, the Department of Public Health and the Department of Community Health share data to indicate which of their providers are providing services with Babies Can't Wait, which of their children are receiving Babies Can't Wait services, and then doing more to kind of align those systems so that we have the opportunity for quality improvement over time. Home visiting, we've talked a lot about during this study committee. We, as a state, are doing some incredible work around home visiting across our state. Home visiting really serves to address some of the common barriers that mothers and children experiencing accessing healthcare in some of our most rural areas. I know Chairman Hatchett said, why don't we have this statewide? Totally in agreement with you. Some options around how Medicaid can support home visiting, and you'll hear more about some of this from Natasha Taylor with Georgia Watch, but thinking about creating a credential for community health workers. Community health workers are a really important part of our home visiting workforce, exploring options for Medicaid reimbursement for community health workers. Again, thinking about home visiting within that case management hierarchy. And then we've talked a lot about PHP, the Perinatal Health Partnership, but there are also a number of home visiting models that are funded through federal funding called MICV, the Maternal, Infant, and Early Childhood Home Visiting federal funding, and we have an opportunity to access enhanced federal funding by investing in some of these different home visiting models. And then the last is looking at leveraging flexible federal dollars to support Babies Can't Wait and home visiting, such as through the CHIP Health Services Initiative, which is a way of kind of tapping into some of the unused CHIP administrative dollars. Other states have used these dollars to fund early intervention and home visiting. GEARS is working with some partners around pulling together a white paper that would explain this in more detail, so I'm hoping I'll be able to get that to you all shortly. And that's that. I'm happy to answer any questions to the best of my ability, and again, I really appreciate you all having us out here today to talk about this really important topic.
Thank you very much. We do recognize how important Babies Can't Wait and the impact it makes on these early lives of these children. I can't see, are there any questions?
I just have one. Yeah. Can you give me an example of what you're talking about with number one, with
Case management.
the case management?
Yes.
So tell me give me a real life scenario of what happens with a child.
Yeah.
You know, with trying to get billing.
Yeah, so Ansley actually talked about this when she did her presentation during the last session. But when a parent is still in the hospital, a service coordinator from Babies Can't Wait will meet with them and say, okay, you are now the parent of a child with a disability. Your life is going to look a lot different. You need to, set up all of these different therapies for your child. You might need to get a wheelchair, a different type of car seat than what you expected to have. So there's a lot of kind of logistical pieces that service coordinators can help with. They help with setting up those different appointments. And right now that is coming, that support for families through case management is being billed out of the block grant rather than through Medicaid. But it is a service that Medicaid would reimburse for with this hierarchy issue. We have a code already.
We have a code already.
Mm-hmm.
Okay. But you said that somebody can only bill one time a month.
Mm-hmm. And an entity can only bill one time. Yeah, there's only one. And only one entity can bill per month.
So if I have a child that has multiple visits in a month, what does that mean?
You mean multiple, like, case
Different.
management?
Mm-hmm.
I would need to look into that a little bit more.
Okay, I don't see any other questions. Thank you very much. I appreciate it. Our next presenter will be Natasha Taylor.
Thank you, Chair Taylor, no relation. And thank you, members of the committee. My name is Natasha Taylor. I am Deputy Director of Georgia Watch. We are a statewide consumer advocacy organization focused on the issues that impact the quality of life for consumers across the state. We also lead the Community Health Worker Advocacy Coalition. I have led that at the Commission of the Department of Public Health since 2018. So what is a community health worker? I know you've heard that term mentioned a couple times today, but I want to just clearly define a frontline public health worker who is a trusted member of a particular community and or has a close understanding of that community. And I'll dig more into what that means for communities. They act as a non-clinical asset to an individual's care team, and they build individual and community capacity by increasing health knowledge and self-sufficiency. Excuse me. So why community health workers? Georgia faces severe shortages in primary care and behavioral health providers, especially in rural and underserved areas, as we've already talked about. Hospital closures and workforce gaps limit access to timely, quality care. Health disparities remain stark for low-income, rural, and other underserved communities across our state. Community health workers bridge these gaps by extending the reach of the healthcare system, addressing social determinants of health, and providing trusted support where providers are scarce. So what's at risk right now? Without stable funding for community health workers, much like Callan pointed to with the maternal health program, provider shortages in primary care and behavioral health and maternal health will deepen. Again, continued hospital closures and workforce gaps will leave even more communities without access to timely care. Health disparities for rural, low-income, and underserved Georgians will widen, and the progress that CHWs have made in building trust and connecting people to care could be lost if positions disappear when grant funding ends. And when I talk to community health workers across our state, they're all primarily grant funded right now in the state. They're not worried about losing their jobs when that funding runs out. They're worried about the communities that they're serving. We have one rural CHW that I spoke with that works a lot with the farming community, and she said she has over 100 clients that would lose access to resources if she loses funding for her position. So in 2021, I just want to talk about some proven success of CHW integration. DPH received funding to address COVID-19 and future public health disparities. They integrated 26 CHWs across Georgia, and this included within 12 funded public health districts. The CHWs received comprehensive training to equip them for their roles, including core competencies, chronic disease prevention, behavioral health, and COVID-19 basics. Those CHWs provided over 76,000 referrals to chronic disease management, housing, food, and preventative health services, representing a significant increase from approximately over 1,600 referrals in the program's first year. Education and messaging from these CHWs reached more than 3.6 million Georgians, showing again their reach and their trust within communities. Although this program was successful, without sustainable funding, it wasn't able to continue. So when these grants ended, those CHWs lost their positions, even though the need for the services continued. This creates a revolving door. You have trained, trusted CHWs who are embedded in communities, but then displaced, leaving gaps in care and eroding community trust. I want to highlight very quickly some other Georgia CHW training programs outside of DPH. You have the Emory Archway program, which had 476 CHWs trained over the past 2 years. Morehouse School of Medicine, which has been training CHWs for more than 20 years, trained over 1,100 CHWs through their Innovation Learning Lab programs from the year 2024 through now 2025. This is an increase of 6,500 from the prior year. So that's over 1,600 community health workers in our state. And many of them, due to limited funding and the facts that they're only billable under a few specific programs in Georgia, struggle to secure long-term stable employment after completing their training. So this is a highly underutilized workforce where thousands have been trained, but there's no funding to support them and to deploy them into the communities where they are needed most. CHWs pay for themselves. I have some data here from a couple states similar to Georgia. In Texas, we have 2 East Texas hospitals that reported a 3-to-1 up to a 15-to-1 dollar investment return from the embedding of CHWs into programs. This was specifically around frequent emergency department users. Savings came from fewer avoidable ED visits and stronger outpatient follow-up. In Florida, we had a Miami intervention that showed A1C reductions with CHW support. CHWs improved type 2 diabetes and cardiovascular outcomes through education and, again, navigation to resources. A Pennsylvania University study reports a $2,500 net savings per patient per year. That's a high return on investment, averaging about to $2.47 per $1 invested in community health worker programs. Again, uplifting with what Jessica started out with. When you take care of individuals, it benefits the state as a whole. So it's really important to invest in a workforce that can reach individuals and, again, support our public health professionals and our public health providers. I want to uplift really quickly. Given this ROI, we're waiting for new data coming from a program that is now being implemented at Decatur Fire Department. Again, showing the scope of how CHWs can be implemented. At the Decatur Fire Department, over 60% of their calls were non-emergent calls, most coming from senior communities where the seniors just wanted someone to come check on them. They may have needed a ride to the doctor or to the hospital. And so they're implementing CHWs through Agnes Scott University to try to mitigate and direct those seniors to resources. So again, it's showing, someone said earlier, thinking outside the box when utilizing this workforce. We did introduce legislation. Thank you to Chair Taylor for sponsoring House Bill 291 last session. The benefits of certification are outlined here, but again, provides that credibility, and with so many CHWs being trained, also streamlines the core competencies that they are receiving. Again, it pours into workforce development and improved outcomes for our communities, and again, a boost in business with that return on investment. That bill did make it out of the House. Thank you to the House again for moving that bill, and thank you to Chair Parrish for getting it out of rules on crossover day. But it did get stalled in the Senate, so we're looking for that to move through the Senate next session. It will come back to the House with a minor amendment around the fingerprinting in that bill. So finally, our legislative and budget solutions, again, supporting a state-recognized certification for community health workers to streamline training, supporting a Medicaid state plan amendment for sustainable reimbursement, and one note about the state certification that will be housed under DPH. That's how the legislation reads right now. It will just form a committee to establish what the state will do when it comes to certification for CHWs, and then invest in permanent funding streams to stabilize the CHW workforce beyond short-term grants. Any questions?
I don't see any questions, and thank you for this presentation and for what you're doing.
Thank you.
Appreciate it. Our next presenter will be Leah Chan.
Hi, good afternoon. So I'm Leah Chan. I am the Director of Health Justice at the Georgia Budget and Policy Institute. So we are a nonpartisan, nonprofit organization that does research and advocacy really focused on our state's budget. And actually, prior to coming to Georgia Budget Policy Institute, I actually worked for over a decade in Atlanta at the Centers for Disease Control and Prevention. So I just want to say thank you to Chair Taylor and Morgan and the committee. As a public health nerd who also loves state budget, this study committee is basically a dream for me. And I just wanted to say thank you to all the amazing members of our state and local public health departments who have spoken to us over the past 3 meetings, I really think that we in Georgia are so lucky to have such an incredibly talented and passionate workforce that often does work that is invisible but incredibly critical for our state. So I'm going to talk a little bit about our current investment in public health and then just basically reiterate some of the key themes we've heard over the past 3 meetings, budgetary themes, and talk about sort of what opportunities they present to us. So across the United States, not specific to Georgia, but across the United States, public health has really been historically underfunded, particularly when compared with healthcare. So since becoming a standalone agency in 2011, state general fund appropriations for Department of Public Health have never surpassed the $500 million mark. So let's say we have $10 to spend, 10 state general fund dollars to spend in fiscal year 2026. 7 of those dollars are going to Department of Community Health. Almost 3 of those dollars are going to Department of Behavioral Health and Developmental Disabilities, and less than $1, in fact, closer to about 60 cents, is actually going to Department of Public Health. So state investment is somewhat oriented downstream towards catching Georgians when they're already sick, already injured, already in crisis, rather than really keeping communities healthy and addressing preventable health conditions. So in Georgia, we've really seen that total state and federal funding has actually been trending downward over the past longer than a decade, about 13 years. So state general fund appropriations for public health have increased from about $18 per person in fiscal year 2012 to about $34 in fiscal year 2025. And that biggest year-to-year jump was in fiscal year 2023, and it's primarily accounted for by salary increases for some job categories that we've talked about, like public health nurses, epidemiologists, and environmental health staff. But even with those salary increases, several of those categories are still not even at market average. So despite this modest increase in state general funds, what we see is that total per person funding, so that's total state plus total federal funding combined, has actually decreased since fiscal year 2012 from about $97 per person to about $74 per person in fiscal year 2025. And unfortunately, during that same period, we also see that death rates among Georgians under 65 have been trending upwards, and too many Georgians are dying too soon of preventable causes like suicide, drug overdose, and heart disease. However, as Dr. Schwinn really broke down for us this morning, the good news is that public health can save lives and save money for our state. So we know that health is more than what happens in the doctor's office, and it's actually public health interventions like improved sanitation, access to family planning that were the most significant contributors to Americans leading longer, healthier lives in the 20th and early 21st centuries. We know that increases in public health spending have actually been shown to reduce preventable deaths, and healthier communities really support stronger economies. And we also know that public health really delivers a strong return on investment, as Dr. Schwinn talked about this morning. And so one literature review found that on average, for every dollar that was spent on public health, it yielded about $14 in savings across health services and the broader economy. So let's talk about a little bit about some of the themes we've heard over the past 3 meetings from sort of a budgetary perspective. So we know that federal funding accounts for about half of our Department of Public Health's total funding, and based on one of the presentations we heard today, that sounds like it's about standard across the United States. So we know that short-term federal funds during emergencies like COVID-related funding can support state-level responses to outbreaks, disaster-related responses, and other emergencies, whereas some other ongoing federal support for core programs like WIC funding from Department of Agriculture helps hundreds of thousands of Georgians who are pregnant or postpartum and their kids get access to healthy foods. But for decades, what we've seen is that federal public health funding has followed this sort of boom and bust cycle with surges during public health crises and then sharp cuts during economic downturns or sort of political shifts. We also know that federal funding is often tied to specific diseases or conditions in which there is it's very time-bound, and there are specific outcomes you have to meet, which doesn't really allow for the flexibility that's sometimes needed to respond to more local issues. So what we know is that state and local funding could really be a counterbalance to that. To that uncertainty, and sort of make sure that we have those foundational public health capabilities at the district and county level, and that they remain constant and widely available. So flexible, consistent, and adequate state and local funding are really the cornerstone of building and maintaining a robust public health infrastructure. And Georgia's already part of the way there. So our general grant and aid funding is, we know it's already flexible. We know that the Georgia General Assembly has consistently provided these funds over time. In fact, the public health funding formulas provided to the counties accounts for about half of total state funds for Department of Public Health. But where we have some room for improvement is providing sufficient funding to build and maintain sufficient and robust public health infrastructure. So let's pause there and talk about what do we mean by that. So our individual public health programs like rabies control or breast cancer screening are only ever going to be as successful as the foundation on which they are built. And that foundation is commonly referred to as public health infrastructure. So this slide has just 3 examples of some components of public health infrastructure. For example, modernized data and technology systems with timely, accurate, and actionable data. We talked about the PDMP. We've talked about in previous meetings the transition to EHR from paper and fax. We've also talked about the need for sort of that well-trained, diverse, trusted, equitably paid workforce. So these are sort of some of the components of a strong public health infrastructure. So adequate investment in Georgia's public health infrastructure ensures that the state can respond to whatever comes its way. So future health threats, like infectious disease outbreaks, while also strengthening our ability to address ongoing issues like heart disease and maternal mortality. So Georgia also has this really unique 159 county health department footprint with district level and county level staff who live and work and understand their communities. But I think what we've learned over the past several meetings is that funding and foundational capacity do vary across those local health departments. So an opportunity before us that was mentioned by our speaker from the Public Health Accreditation Board is that there are standard tools available that we could use to do an assessment of those public health capabilities and cost to really inform potential funding formula updates. So as we've talked about, 2 of our primary funding formulas are the county participating funds. That's what the county has to provide in order to draw down the general grant and aid. That funding formula was developed in the 1970s and is calculated using 1970s population and tax digest data. And then there's the general grant and aid funding formula based on a formula that was updated in 2011, and it's calculated using population, tax digest, and also layered on poverty data. So we do have an opportunity to sort of use a standard tool like the one from PHAB to really determine what is our current spending and capacity towards those foundational public health services look like at the county and district level, and what investments are needed to sort of fully implement that foundational public health capacity in whatever way that may look. So that sort of deeper data dive could help us better understand what do we already have, what's missing, and what level of funding could sort of get us there, and how can we use that information to update our funding formulas. And I do want to be very clear, because I think this was sort of alluded to earlier in the discussion, that we could use this tool to fit the needs of our state. So we have some counties that are never going to meet foundational public health capacity because they are just too small, and it doesn't matter how much money they get, and that's okay. But this tool sort of gives us the data to figure out where are the gaps that can be filled either with additional funding or with greater collaboration with other counties that sort of do have that capacity. And as Graham said, we already do have master service agreements in place that list out what counties are expected to do with their general grant and aid funding. So this is just an opportunity to be additive and to sort of figure out how we might better support states, support counties in getting that foundational public health capacity, and not intended to sort of penalize counties. And again, in addition to sort of updating the funding formulas, we could use it to establish some, layer on to the master service agreements and establish some minimum standards, make sure health departments have adequate funding to meet those standards, and then establish some key performance indicators to sort of maintain that accountability. So another key theme that has come up is that the cornerstone of our state and local public health system really is the people. We have over 5,000 state and local public health workers who have a reputation of being mission-driven. I was really incredibly moved at the last meeting, in particular by the nurse from Representative Osteen's district, who talked about how passionate she was about the perinatal home visiting program, and that for her it is really a ministry. And I think that is something that you hear from a lot of public health folks in our state, who are really filling a range of critical sort of positions, from inspecting restaurants to prevent foodborne illness, to doing vision and hearing screening so kids are prepared for school. So we have also heard a sort of a key theme coming up is that one of the primary barriers to success is retention and recruitment of qualified staff. We know that public health salaries cannot compete with salaries in the private sector. And while there are people that really truly do have a passion for this job, sometimes economic pressures force them to seek out other opportunities. Just to sort of drive from that point here, you can see that the public health district that covers Stewart County is currently recruiting an RN with an associate's degree and 1 year of experience, and that's would be about $59,000 per year plus benefits. In that same county, Stewart County, a private healthcare company is hiring with an RN with an associate's degree, 1 year of experience at a pay rate of $83,000 per year plus benefits. So there are some challenges. In addition, there are unique skills and training required. We heard about sort of the unique skill set that sort of requires on-the-job training for those environmental health specialists. And we know that at our state level Department of Public Health, we have 1 in 5 workers who are retirement eligible within the next 5 years. So there is an opportunity here for a sort of rural salary study and workforce needs assessment to really help us better understand how can we build the talent pipeline, how can we provide incentives and equitable pay to folks taking hard to fill positions, particularly in those rural areas, and how can we better leverage some of the non-clinician positions like what our colleague from Georgia Watch just spoke about, for example, with community health workers. So lastly, we also heard in the last meeting about the different partnerships happening at the local level between health departments and local healthcare providers or local social service providers. So we know that the 18 public health districts are a great model because they are comprised of 1 or more counties that allows the county health departments to share resources and administrative staff as needed. We also heard that the federal qualified health centers are collaborating with their local health departments. We also know, for example, social service providers are collaborating with their local health departments. Just one example, in Chairman Parrish's district in Emmanuel County, there is a partnership between the Department of Public Health there and Family Connection as they're working to enroll more folks in the WIC program and get more folks access to healthy food. So there's an opportunity to really incentivize, further incentivize these shared services and staff across county health departments, and possibly sort of reorganize those public health districts as needed to sort of balance out where the needs and resources are. We also know that there are opportunities to incentivize and really simplify resource sharing and co-location with local healthcare providers, like federally qualified health centers, our DBHDD's community service boards, and with some of those social service providers. Again, in particular, this could really be sort of a force multiplier in our rural communities, as Dr. Scoggins talked about, where there isn't economy of scale. And so this provides an opportunity to maximize capacity and decrease some of that administrative burden, while also making sure we're not offering sort of redundant services and making sure we're maximizing the resources available in that community. So there were other key themes that I don't have time to talk about that others are much more expert in, around the critical role that public health plays in supporting maternal and child health, the challenges we face with emergency and non-emergency transportation, the critical importance of transitioning to EHR, and then, as Natasha just spoke about, the CHW workforce. So as sort of a summary here, I think what we have learned in totality is that our state's health security and our economic well-being really depend on a thriving, fully funded state and local public health system. And public health across the nation, including here in Georgia, are really post-COVID at a crossroads. And we have this unique opportunity right now to really build on our state's many strengths and continue to modernize and take us into the next era. And we know that more funding alone, that's not the answer. It really is going to take sort of intentional, data-driven effort, which is why we're so lucky to have this study committee here, thinking about new ways that we can modernize our state's public health system. So with that, I will take any questions, and I do apologize for not having a photocopy, but I will make sure you guys get that as an email attachment.
Thank you very much. Chairman Parrish?
Thank you. I want to ask you to talk just a little bit more about the collaborative efforts that you mentioned about some of the FQHCs and the health departments. Is there anything in the health department that prevents them from seeking out more of those collaborative efforts? And what I'm particularly thinking about is in small communities, small counties where, like in our health department, we don't have somebody in there every day that maybe is an RN or something. Is there anything that prevents that health department from seeking to enhance the collaborative agreements that are out there?
Yeah, that's a great question. So I'll talk that in two parts. So the first is when we're thinking about shared space, obviously there have been county health departments that have been able to surmount this barrier, but the county has to provide space for the county health department. So that is county-owned or county-leased space. So that could be potentially a barrier when thinking about what does it look like to share space with a federally qualified health center, so that even if the public health nurse isn't there every day, the staff from the federally qualified health center could be. And then in terms of the specific sort of informal or formal agreements happening between FQHCs and county health departments, I would maybe have to defer to Graham or one of the FQHCs. I mean, I think as the presenter from Public Health Accreditation Board talked about, I mean, it runs the gamut from informal to formal, so it could be an MOU, it could be sort of joint purchasing of some, tranche of vaccines, it could look really different what that collaboration looks like. And I don't know the specifics of what is allowable. I just know that there are examples of ways in which we could potentially make it easier for those collaborations to happen.
Thank you.
Thank you. Are there any other questions? I don't see any other. Thank you very much. It was very informative. Thank you. We have one final speaker, and that's Nancy Petra. If you could come up, please.
Can get the slideshow started for me. Perfect. And then I just need to hit this, right? If I can hit that, that'd be Good morning. Or afternoon now, I guess it's afternoon, isn't it? So thank you. I appreciate Chair Lady Taylor adding me to your agenda today so that I can talk to you and the members of the committee. My name is Nancy Petra. I am the Director of Government Affairs for the Alzheimer's Association, the Georgia chapter. I'm here to talk to you today about the impact that state investments in Alzheimer's and dementia and brain health at the Department of Public Health have had, because these state investments are ensuring that Georgia really is a leader in brain health and reducing risk of Alzheimer's and other dementia. And so there are other state investments that are also being made at the State Unit on Aging and the Department of Community Health. I'm not really going to touch on those. I really kind of want to focus, since we're here about public health, to tell you about the great work that we're doing there. I want to start, though, by telling you about the state plan. And the reason is that this was in response to the growing number of people with Alzheimer's disease and related dementia. Early on, the Georgia General Assembly was an early adopter of the need to have a state plan task force back in 2013. Before a lot of states were even looking at this, we were an early adopter. And the Department of Public Health was one of the leaders in this collaboration as we codified our plan in 2014. And one of the first recommendations that came out of the state collaborative was the funding of an Alzheimer's registry within the Department of Public Health. So in the fiscal year 2015 budget, $110 was put into the Department of Public Health's budget to put together the Alzheimer's disease registry, to collect data, to contract with CMS to get Medicare claims data, so that we could better inform state representatives about what this burden was looking like, so that we could inform programs for older adults services, and we could track trends. And then a few years later, the next recommendation that came out of the plan was that we needed to build awareness. We needed a little more funding. So one-time funding of $350,000 went into the 2019 Department of Public Health budget, and that became what's now known as the Think About It campaign. So this was one-time funding that allowed them to create a brain health awareness campaign around the need for cognitive assessments in the Medicare annual wellness visit. And there were radio spots, there were billboard ads, there were presentations during CVS, and we had the Z card printable materials that were out in local health departments and through community partners. And even though that was one-time funding, that campaign still is ongoing. But the timing of this funding was critical for both of these initiatives, because in 2020 was the first time that the federal program for BOLD was created, and BOLD funding was going to be administered by the CDC. And so a handful of states were in a good position to get what was called an enhanced BOLD grant, and Georgia was one of those. So the Georgia Department of Public Health was an early enhanced state to get the Building Our Largest Dementia Infrastructure grant. The first grant was for 3 years, and then most recently they were awarded new funding for another 5-year grant. So what do we do with that money? So the BOLD grant aims to create and increase community clinical linkages in Georgia, promote a comprehensive systems-level approach to dementia risk reduction, diagnosis, care, and support. The BOLD team is focused on addressing the Healthy People 2030 goals by supporting the actions that are outlined in the CDC's Healthy Brain Initiative. The Department of Public Health has used the funds in several ways to break down silos of work, ensuring different public and private initiatives are complementary and not duplicative across the state. They have empowered public health clinics to incorporate risk reduction into chronic disease management, conduct memory screenings, and partner with both community health workers and dementia care specialists as a regular part of their public health work. Thank you. Other major areas of focus for them with these funding is workforce development, where they are creating dementia training modules for EMS and encouraging more timely diagnosis for Georgians, including increasing access to diagnostic tools. So what else are they doing? So the Department of Public Health BOLD team is collaborating closely with our Georgia MemoryNet memory assessment clinics. Now, the Georgia MemoryNet is funded through the State Unit on Aging, so in the Department of Human Services budget. But we've been able to utilize that BOLD funding that's come in from the CDC to expand that reach. So they're collaborating with GMN, again, to promote the Medicare annual wellness visit, to continue to utilize that Think About It campaign that we had that one-time funding for, working with targeted local health departments to incorporate healthy brain modules into their messaging on prevention education across chronic disease. So many people that have an Alzheimer's diagnosis also have another comorbidity like diabetes and hypertension. So it is very important to get all that messaging across other chronic disease messaging. And they have been able to expand the reach of our memory assessment clinics through telehealth locations and our county health offices. I cannot tell you the number of times that I get a call from one of my colleagues across the country that says, we want to be Georgia. And it is not just because of what we've done with the GMN, the brick and mortar spots, but how we have utilized the BOLD funding to increase our access to telehealth. When you look at some of these spots, we still are not, we have neurology and specialist deserts across the state. So to be able to have local telehealth in Emmanuel County where someone can go and get that cognitive screening earlier and not have to wait or drive hours to get to Emory or to, Augusta University or to somewhere where we have a neurologist is critical and is helping us to diagnose and get people the care and support that they need earlier. So you've heard a lot of testimony, I believe, over these 3 meetings about collecting data, and so I don't want to go into that anymore, but just to say that this is one slide. There's a link there to the OASIS, their platform is their online platform where you can look at all the different data and you can analyze it a little bit. And they do have a whole thing on Alzheimer's disease and related dementia. And this is just one map. So this shows prevalence among Medicare beneficiaries by public health district. You can break this down by county. You can break this down by your house districts if you would like. You can break it down by the sex of the people that live there, the age of the people that live there. I will say that we are limited. A lot of our data is Medicare data. So again, thank you to our General Assembly. Last year we went and the Alzheimer's Association advocated to increase, because the last 10 years all we've had for data collection support at the Department of Public Health was that $110,000 that was put in 2015. So last year we worked with the General Assembly to increase that. We were just covering a Medicare data contract and part-time epidemiologist to work on this collection and analysis. And now we will have the needed support that they need to hire some more staff and to be able to expand that reach, because we really want to understand how this burden is on Georgians. And we know that younger Georgians are being diagnosed. Just in my community alone, last week at my son's school, a mother at 48 just died of young onset Alzheimer's. She was diagnosed at 44. So we've got to start catching this burden and understanding that earlier. And I also just want to say, when it comes to understanding and analyzing data on OASIS, the DPH BOLD team, they are not just collecting the data and analyzing it internally and looking at it across other chronic disease management, but they are also educating our other state units, their public and private partners, on how to analyze that data and use that when they are working with their stakeholders and others to work on brain health messaging. So I want to just kind of leave you with one final thing today, because one of the things that I hear all the time at the Alzheimer's Association and my partners at the Department of Public Health and the State Unit on Aging and everywhere else is, how can we improve brain health? How do we reduce the risk? And all these brain health messaging, how can we do it? We've always sort of known, or we've been able to suggest, that about 40% of the factors that contribute to you getting dementia are modifiable. There are those ones that are not. Age and genetics are not, but 40% of the other factors are modifiable. So we've known that, but we've never really had the rigorous critical data to really connect the two until this summer. So we're really pleased to say that the U.S. Pointer Study, which was a 2-year rigorous clinical trial, we were able to present that at our big conference and present the results of that, which showed that lifestyle interventions in large, diverse populations of older adults at risk for cognitive decline and dementia were followed for 2 years in this trial. They were randomly assigned to either be self-guided on these interventions or in a structured lifestyle program. I'm happy to report that both interventions focused on increasing physical activity, improving nutrition, cognition, and social challenge and health monitoring at different levels and accountability and support, but that everybody improved. So that's the good news. Remarkably, the cognitive function improved over the 2 years for both of the groups. However, the group that received the more structured support showed the greatest benefit, including helping to protect thinking and memory from the normal decline that often comes with aging over that 2-year period of study. So now we want to understand, what do we do and how do we implement this? And of course, we need to look to our public health to see how to best get this across our rural communities. So I'm pleased to announce that the National Alzheimer's Association has awarded a grant to the Georgia Department of Public Health because of all the wonderful work they are doing to see how we implement this types of structure across our communities and continue to improve brain health messaging and hopefully prevent dementia diagnosis and improve those risk reductions. So there's a lot of great work going on at the state level at the Department of Community Health, the Public Health, the State Unit on Aging, and the Department of Community Health. These agencies are all working together and sharing data. They serve on the advisory council for the GUARD State Plan. And I want to thank Commissioner Toomey for her leadership and support with all the great work on brain health going on at the Department of Public Health. It is great to be a Georgian. It is great to go to conferences and say that we're doing so much great work here. We still have more to do. Dementia and brain health is a marathon. It's not a sprint. But I absolutely could not do it without the BOLD team at the Department of Public Health. And I just wanted to highlight some of that for you guys today. So happy to take any questions.
Yes, go ahead.
Quick one here. Thank you so much. I do a lot with the Alzheimer's Association myself in South Georgia. But where can the community health workers, kind of help in this situation? Because you have a lot of people, the older community, but how is there some type of connection actively going on now?
Yes. So when it comes to sort of educating the communities and those partnerships that the Department of Public Health uses, they reach out to a lot of different groups because we need to meet people where they are, and they want trusted people in their communities. So whether we are working with our faith-based communities or our educated community health workers who are the trusted individuals in those communities, they are helping to kind of educate them. So it's not just, are you managing your diabetes, how is that also affecting your brain health? So we're using, the Department of Public Health is utilizing them that way already. And when we are looking at how we're going to implement these types of interventions in a structured way and how we might need to do that, I think the community health workers are going to be critical to that too.
Right, that's what I was thinking, that, the connection. Thank you.
Yeah.
I don't see any other questions, and I want to thank you for your presentation. At this time, I want to thank everyone that has worked with us on this committee. This is our third and final meeting. We've seen the broad spectrum of what the health department in the state of Georgia does. It has far-reaching across our state and to everybody's lives. So we've got a lot of data to go through, and again, I want to thank you all for your participation, and we are adjourned.